Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in.
Today, we're focusing on neurological emergencies. Let's get started with a lecture brought to you by Josh, one of our content creators. Afterwards, we'll wrap up with 10 multiple-choice questions for review.
Welcome. This course is going to offer an introduction into neurological emergencies, which are a very broad category of emergencies that, as the name implies, relate to disorder or some dysfunction of the nervous system. So a quick outline of what we're going to cover in the course today. We're going to start with an overview of the basic organization of the nervous system. That's really important background information to have, not just for neuroemergencies, but really more broadly in emergency medicine. We're going to cover an assessment of neurocomplaints, the things we want to look for, the assessment tools that we have to gain a little bit more understanding and form a good opinion about what might be going wrong with the patient and what they might need to fix that problem. And then we're going to cover a lot of specific neurological conditions. We're specifically going to go over strokes and seizures, which are really important to understand. And then we're going to cover a lot of just miscellaneous disease processes that you might encounter in the field, just to give you that background knowledge so you know what's going on with patients who maybe have a history of a certain condition or who are presenting like a certain type of condition. So we'll start with just that basic overview of the organization of the nervous system. The functional cells of the nervous system are known as neurons, and those carry electrical impulses. Everything going on in your brain, all the signals that are telling your muscles to move and telling you to talk and understand information, all of that information travels along electrical impulses that are carried through neurons, which are very specialized cells of the nervous system. We divide the human nervous system into two major subdivisions. The first one is the central nervous system, which includes the brain and the spinal cord, and then the peripheral nervous system, which has a couple divisions within it as well, and those are the autonomic nervous system and the somatic nervous system. If you were to pick one part of this to know and really understand, to gain a lot of background information in emergency medicine, it would be the autonomic nervous system. That's what we're going to focus on in a little bit of detail here. So we'll go in depth into that autonomic nervous system. It's really important to have a little background information in the autonomic nervous system, not just for neuroemergencies, but a lot more broadly. A lot of baseline human physiology is related to this autonomic nervous system. It's going to control a lot of our vital organ systems through a lot of different nerve pathways through the body. It's got a lot of major effects on cardiac output to be aware of. Your autonomic nervous system can control things like your heart rate and your blood pressure, control a lot of these vital conditions that are required for life. And the goal is to maintain those vital conditions in the ranges that we need them. We need a certain blood pressure, a certain temperature, a certain heart rate, and your autonomic nervous system is there to make sure those values stay within their appropriate ranges that we need them to be. We have these two opposing subdivisions, which is our sympathetic and our parasympathetic nervous system, that compete with each other to find those vital conditions that are required for life. The first one we'll cover is the sympathetic nervous system, oftentimes referred to as the fight or flight side of our nervous system. The chemical mediators of this side of our nervous system is epinephrine and norepinephrine, and those interact with alpha and beta receptors. A lot of the medications we use will interact with those same receptors, and epinephrine and norepinephrine are both actually drugs that we can administer to patients. Your sympathetic nervous system is going to cause a lot of broad effects. The image here shows a lot of those kind of more diverse effects. But big things to understand is we're going to have an increase in heart rate, contractility, and peripheral vascular resistance. So the heart is going to beat faster, it is going to squeeze harder, and peripheral blood vessels will clamp down to make sure they are supporting a good blood pressure. The sympathetic nervous system also results in dilation of the pupils, which means the pupils get bigger. And it does tend to make patients sweaty or diaphoretic, and it also causes dilation of the lower airways. It relaxes the smooth muscle tissue in the patient's lower airways to make it easier for them to breathe. We call it the fight or flight nervous system because you can kind of intuitively think of the effects as what we would want if we were running from a tiger or dealing with a really stressful situation. That's the basics of the sympathetic nervous system. These are all kind of increaser responses, right? An increase in heart rate and an increase in cardiac output more broadly. The other side of the autonomic nervous system is the parasympathetic, or the rest and digest, we oftentimes call it, side of our nervous system. The chemical mediator in most cases here is acetylcholine, and that interacts with two different types of acetylcholine receptors, which are called nicotinic and muscarinic receptors. You might not need to know that, at least at the basic level, but it's good background knowledge to have, especially in higher levels of emergency medicine. The result of the parasympathetic nervous system is largely opposite to the sympathetic side. We have a decrease in heart rate, and we have slowed conduction through the heart, and so we have a decrease in cardiac output, at least through slowing of the heart rate. The parasympathetic nervous system doesn't actually directly innervate the entire heart, so we don't have big effects on contractility, we don't tell the heart to squeeze less hard, and we don't have big effects on peripheral vascular resistance either. The parasympathetic nervous system doesn't necessarily tell blood vessels to relax. We really rely on that sympathetic tone, we call it, to maintain good blood pressure, at least in our peripheral blood vessels. Parasympathetic side also, along with that rest and digest terminology, does increase digestion. That's probably less important in emergency medicine, but it is still relevant to what the parasympathetic nervous system does. The sympathetic and parasympathetic sides are always working. They are always kind of competing with each other to find a good balance to make sure that we maintain the conditions that are required for life, that our brain gets the blood supply that it needs to get. The other big side of the nervous system, or the peripheral nervous system, is going to be the somatic nervous system. And this is a lot of our motor and our sensory information. Sensory information travels toward the brain. We call those afferent neurons if they're traveling towards the brain. And motor information travels away from the brain, along efferent neurons, we call them. And that's just how we control our movement, right? It's how our brain controls other things other than those broad kind of conditions that are required for life. That happens on the somatic nervous system. So a little bit of terminology to kind of apply this information, kind of apply the effects of the autonomic nervous system to maybe what we might encounter in a patient or what a given drug that we administer might do. So sympathomimetic, sympatholytic, parasympathomimetic, and parasympatholytic. We have two prefixes here, right? Sympatho or parasympatho, referring to the kind of opposite subdivisions of the autonomic nervous system, and then our suffixes, which are mimetic or lytic. Mimetic refers to mimicking of those effects. Lytic refers to opposition to those effects, right? Taking those effects away. So sympathomimetic is referring to agents that are going to mimic the effects of the sympathetic nervous system, things that might increase the heart rate or blood pressure or cause pupil dilation or something of that nature. Sympatholytic is the opposite. Those are things that oppose sympathetic activation. So that might cause pupils to become smaller, or might cause the heart rate to go down or blood pressure to go down. Parasympathomimetic is going to refer to promotion of parasympathetic effects, so things that maybe are going to decrease the heart rate or increase digestion. And then parasympatholytic is agents that are going to oppose the parasympathetic nervous system by maybe increasing the heart rate or opposing digestion, for that example. Great example here is albuterol. Albuterol is a drug that is in the scope of an EMT basic, and it is a sympathomimetic drug. It promotes function of the sympathetic nervous system, specifically on our lower airways. It activates beta-2 receptors in our lower airways to cause those lower airways to become bigger, to dilate the lower airways and help us breathe better. Lots of the medications we give can be described in these terms, right? A lot of medications we can say are sympathomimetic or sympatholytic, and so it's good terminology to kind of broadly understand. Like I said, the autonomic nervous system is really important. It's important to have that background information, and it's important not just in neuroemergencies. It's important a lot more broadly in emergency medicine. So that was just a brief introduction into the organization of the nervous system and some of the in-depth knowledge of the autonomic nervous system that we want to have. That's definitely an area that is worth committing to spending some time studying and learning a little bit more in depth. This is there to give you a great introduction into that nervous system organization. We'll move here into talking about a neurological assessment, right? How to go about getting more information about neuro complaints and forming an opinion about what might be going wrong with our patient. This is a very challenging assessment tool because neuro complaints are very diverse, and there's a lot of things that can cause neuro complaints. There's a lot of things that can cause altered mental status and headaches and dizziness and all that. We always start with the ABCs, with airway, breathing, and circulation. Remember that anyone who is severely altered or unresponsive isn't going to protect their own airway very well, so we might need to intervene. We might need to take measures to support their airway. Ventilatory support and supplemental oxygen are things we need to do as needed. If the patient needs us to breathe for them or help them breathe, we are going to do that. And if they need supplemental oxygen, we are going to provide it. And then we always want to assess for and treat any signs of hypoperfusion, meaning clinical shock. So if we see signs and symptoms of shock, we want to treat those because those are common causes of altered mental status and neuro complaints in general. So we'll start our assessment here with a few different screening tools to kind of get some introductory information into what might be going wrong with our patient. The first is the AVPU scale. It stands for alert, verbal, pain, or unresponsive. Alert means a patient has their eyes open, they are talking to us, answering questions. That means they're alert. If they are verbal, that means they might be unresponsive, but they are responsive to verbal stimulus. So when we talk to the patient, they will open their eyes and they will recognize us. Responsive to pain means that they require a deep, painful stimulus in order to respond. So we need to do a sternal rub or a trap squeeze or something along those lines to get a response from the patient. And then unresponsive means they are unresponsive even to a deep, painful stimulus. The patient does not move no matter what. We can then talk about our alert and oriented questions. We want to know if a patient is oriented to person, place, time, and recent events. If we say the patient is A&O times 4, that means they can answer all of these questions appropriately. We want to know their name, we want to know where they are, and we want them to tell us where they are. We want them to tell us what time it is. They don't need to know the exact minutes. Breakfast time, lunch time, dinner time will suffice in most situations. And then what's going on. We want them to be able to recall recent events. They can answer all of those questions. We say they're A&O times 4. We can ask some extra questions. We can ask them, who's the president of the United States, what month it is. But those 4 questions are kind of our initial questions to determine if they are alert and oriented times 4, or if they miss a question, right? If they aren't oriented to recent events, then they would be A&O times 3, if that makes sense. We can then talk about our GCS scale. I'll show that on a slide. That's a very in-depth scale for kind of their neurological status. And we'll go over a stroke or neuro exam. We're going to go over that in detail, right? Identifying strokes is all about assessing patients and recognizing the symptoms they're having. We'll go over an in-depth stroke exam here in a moment. And then we want to go over a thorough medical history, right? Answers to what's going on is oftentimes in the medical history. It's oftentimes on their history sheet. You just have to answer or have to ask those questions, right? If you ask the right questions, it becomes very apparent what's going wrong with a patient. We just have to make sure we get that thorough history every time. Even when we're under stress, even a critical patient, we got to make sure we ask those history questions to gain a good idea of what's going on. So this is your GCS scale. You can feel free to pause to kind of review each one. This is scaled from 3 to 15. 3 is the minimum score, 15 is the highest score. There are 3 categories for eye-opening, verbal response, and motor response. Eye-opening earns a total of 4 points potentially. Verbal comes with a total of 5. Motor comes with a total of 6. And we score them according to the sheet here. You can feel free to pause and kind of review this in detail. It's pretty straightforward. It is a scale that we want to make sure we are committing to memory, right? It's one of those things that we have to be able to recall under stress. A lot of ambulances will have a cheat sheet for a GCS scale in the back, but it's one of those scales that we do want to commit to memory because it's very important in the patient's neurostatus. So we can talk about just general assessments here, right? How to go about initiating our response with our patient. One of those things we can look at is just their general appearance. This is kind of across the room glance when you have walked into a patient's home or wherever they are. How are they dressed? What are they doing? What does their face look like? Do they have any facial expressions? Do they look angry, sad, confused? We can gain a lot of information just with a kind of across the room glance at our patient. We want to take a look at our patient's speech. Are they speaking spontaneously, or are they only speaking when pressured? Are they speaking concerningly fast or slow? Is their speech slurred? That's really important information to get because that might point us towards maybe a stroke if their speech is slurred. And does their speech make sense, right? Are they using words that make sense, that actually form a structure, or are they just spitting out words that don't make any sense and we don't understand anything the patient is trying to say? Then take a look at their skin. We're really looking for perfusion status when we look at a patient's skin, right? Is their skin pink, warm, and dry, or are they starting to turn pale, maybe a little bit diaphoretic? That tells us they have a general perfusion problem. They might be in clinical shock. And you can also look for any indications of trauma or injury, especially on the head. If you see lacerations or bruising on the head, that might point us down the route if maybe this is caused by head trauma. Take a look at their posture or their gait, especially when we talk about stroke care. We want to make sure the patient can walk normally, because oftentimes that's the big indication we get is when they all of a sudden have a funky gait, they're walking different than they normally do, or they can't walk appropriately. Those are things we want to take a look at. It's really good to throw in a walk test in any neuro exam, any examination of a patient with any neuro complaint, be it dizziness or a headache or anything like that. Assess the patient's mood, kind of see how they're feeling in that moment. Assess area of thought, especially for behavioral emergencies. Just going in and asking the patient, hey, what's on your mind? What's going on today is a great way to initiate a counter and build a little bit of trust with your patient. Then we assess responsiveness. If our patient is alert and oriented, answering questions, that's easy. If they're unresponsive, if they're altered, we've got to go through those AVPU scales and maybe an in-depth GCS scale as well. So let's talk about altered mental status. Altered mental status is one of the most common complaints we get in emergency medicine. It is very common for this to be either the chief complaint or an accessory complaint, and it has a very long differential diagnosis. There are dozens of different problems that can lead to altered mental status, and we'll go over how to kind of narrow those down and point us in the right direction. It's very important to have a few screening tools to quickly identify the potential causes. There's a lot of mnemonics out there that you can learn if those help you, or just have a set of assessment strategies that you want to go down when you encounter altered mental status, and do the same ones every single time. Assess those patients the same way every single time. You always start with the ABCs. It's very quick to do ABCs in conscious patients. When they're speaking in complete sentences, we automatically know they have a good airway and they're probably breathing okay. But always start with those. If there are any airway, breathing, or circulation problems, we treat those first and we give priority to those problems. Focus on broad, life-threatening conditions first as well, right? Even if it's not airway, breathing, or circulation, if you find any life-threatening problem, we focus our treatments towards that life-threatening problem, and we manage minor problems down the line if we get to them. You can look for clues in your patient's medical history and in their current medications, especially when they don't relay information. We go on a lot of these calls in care facilities where the patient might not be able to relay their medical history. You can take a look at their medical paperwork, ask what kind of medical conditions they have, and look at the medications they take, which will give you really important clues as to the conditions and the medical history that they might have. So we'll start with kind of our skill sheet, or just our general method of going about our altered mental status calls. Once again, always start with your ABCs. Make sure the patient has a good airway, make sure they're breathing appropriately, and we support their circulation as best we can within our scope. Good vital signs to get on altered patients. We start with the basics, with our blood pressure, our heart rate, our respiratory rate, and pulse oximetry. Those are really routine vital signs in EMS. We tend to get those on everyone. Always get a blood sugar in addition to those basic vital signs. A blood sugar is something we always need on anyone with altered mental status, because fixing a low sugar is pretty easy. That's a relatively common cause of altered mentation, is going to be a blood sugar problem. So make sure we're getting a CBG. Make sure we're checking the patient's temperature to see if they might have an infection. We can talk broadly about sepsis, but patients who are sick do tend to develop altered mental status, so that's a really important tool to get. I always remember to get a blood sugar and a temperature in addition to the normal vital signs I'm used to getting on every patient. We can then move into a neuro or a stroke exam. I would recommend doing a thorough head-to-toe neurologic exam on everyone with altered mental status. We want to look for the smallest indications of a stroke that we are capable of finding every single time, because that is a big potential cause of altered mentation, is a stroke, and we want to be there to identify that, right? Not just your basic easy stroke exam. We want to do as in-depth of a stroke exam on altered patients as we realistically can. And then everyone with altered mental status should earn an EKG to see if there is a heart problem or something circulatory related that is leading to their problems. So let's talk about some of those causes of altered mental status. We'll talk about these kind of broadly first, and then we'll go into some really specific conditions that can cause altered mentation. We'll talk about primary intracranial disease. This is where there is something going wrong with the brain that is directly causing altered mental status. So something like a stroke, maybe just a simple history of dementia, maybe a seizure, something going wrong with the brain itself. We can then talk about systemic diseases that affect the central nervous system, so a problem with a different body system that causes altered mentation, something like a circulatory problem, maybe renal failure, sepsis, or diabetes. We can talk about toxins, right? That's anything from recreational drugs to unwanted medication interactions to chemical or hazardous material exposures. Those are things that we definitely want to identify. And then drug withdrawal is a big category. Depending on your EMS system, those might be common calls and that they might be very uncommon, but drug withdrawals are a real problem and they do cause altered mentation. So we'll go over a very common mnemonic for some of the common causes of altered mentation, and that is AEIOU TIPS. This is one of those mnemonics that has a lot of different iterations out there. You'll see the same letters applied to different words, but we cover the exact same things, however they align the letters in this situation. We can cover alcohol. Obviously, intoxicated patients are not going to have fully functioning brains. They will have some altered mentation. Epilepsy cues us in to look for seizures, right? Patients with seizure disorders will develop altered mental status even when they aren't having a seizure, especially after their seizure. We call that the post-ictal state that we'll talk about. Insulin cues us in to think about diabetes and just remember to get a blood sugar. Remember, always get a blood sugar and a temperature in addition to any of your other vital signs. Oxygen, we should be getting an oxygen saturation by default, but think about respiratory failure. Think about any of those things that might lead to altered mentation. Uremia, which cues us into kidney failure. Kidney problems cause altered mental status for a lot of different reasons, and anyone with a history of kidney failure, that is a potential cause of their altered mental status, but we also want to rule out everything else. T is for trauma. We want to make sure we do a once-over of our patient's head, look for any obvious trauma, and maybe ask your patient if you've had any falls recently or had any traumatic events recently that might have led to this problem. I stands for infection. Remember, we always get that temperature. We think about whether or not our patient is sick, and their sickness is causing them to have altered mentation. Psychiatric disorders, behavioral emergencies, right? So we want to know if they have a medical history of this, maybe a history of dementia, maybe a history of a behavioral disorder. Poisoning, so we're looking for drug overdoses, we're looking for hazmat exposures, anything of that nature. Shock, meaning hypoperfusion, so if the brain is not getting a good supply of blood, it's not going to function properly. And then last but definitely not least is stroke. Stroke is something we want to rule out or in early on so that we can identify if that's what might be causing their altered mental status. So we'll talk specifically about the causes in a few different age groups, starting with children. The most common causes of altered mental status in children are going to be infection, trauma, metabolic problems, and toxic ingestion. Infection is pretty intuitive. If a kid is sick, their brain might not work at 100%. Trauma, right? And especially consider non-accidental trauma in your very young kids. Screen for head injuries, whether or not you are told that there is trauma involved, because that is the most often missed chief complaint in child abuse is altered mental status. So we've got to screen for non-accidental trauma in all of our altered children and just screen for trauma broadly as well. Metabolic changes, the very common presentation there is something called diabetic ketoacidosis. The presentation there is an unresponsive child with super fast, super deep respirations that we call Kussmaul respirations, and that's a complication most often of type 1 diabetes. It is a life-threatening emergency and something we want to identify early on as diabetic ketoacidosis or any other metabolic problem leading to altered mentation. And finally, toxic ingestion. Can be medications. Children will get fentanyl patches on them. They will get into household chemicals. They will take their grandparents' cardiac medications. Very broad category here. We want to ask if there's anything a child might have gotten into if they are presenting with altered mentation. Moving up to our young adults, toxic ingestion is a very frequent cause, probably the most common cause of altered mentation in young adults. Usually comes down to alcohol or some sort of recreational drug. And then also consider intentional overdoses, patients taking medications with the intent to harm themselves or end their own life or something of that nature. Then trauma is once again a big factor. Any recent head injuries, any recent trauma is a big question we want to ask when we're gathering history information. And then a less common cause, but a very important one to remember, is subarachnoid hemorrhage. This is a form of stroke. very life-threatening form of stroke that is a common cause of sudden death in young people, and just something to be aware of. Subarachnoid bleeds do kill very young patients very quickly, and that can result in altered mental status. When you show up on a young adult who is unresponsive without a reason, you want to consider subarachnoid hemorrhage every time. Finally, we have our elderly folks. Stroke is a huge consideration. The older a patient is, the more likely they are to have a stroke, and the more likely it is that a stroke is causing their sudden onset of altered mental status. Infection is once again a big consideration. A lot of elderly folks will get urinary tract infections or wounds of any kind or respiratory infections that will lead to altered mentation. And then medication interactions are a big consideration, right? If they have a new sleep aid is a very common cause of altered mental status. You'll go on a late night call for an elderly person who can't wake up their spouse, and you find out that they were just prescribed a new sleep aid. And it's not really surprising that that is happening. It is not ideal. We need to treat them appropriately and get them taken care of, but it's not very surprising that that is happening. So look over the med list on a lot of elderly folks, because they do tend to take a lot of central nervous system depressants that will cause that altered mental status. So we can talk broadly about treatments. Treatments of neuro complaints are very broad. We generally cater our treatments towards the underlying cause, and unfortunately we're not always going to be able to fix the problem. What we do in a lot of neuro emergencies is really assessment. We want to identify the problem so that we can let the hospital know what we're coming in with, and they can prepare to treat the patient a lot faster. Always assess and support ABCs. If you can treat an ABC problem, absolutely do it. If they have a problem there, it needs to be addressed. Appropriate oxygen therapy, so we give oxygen if the patient needs it or if it's appropriate for some reason or another. Consider naloxone or Narcan for narcotic overdoses. Those are mostly there to make sure the patient can breathe adequately, but that is a main reversal agent for opiate overdoses. Any fentanyl or heroin or anything of that nature, we can use naloxone. Oral glucose is our main tool for low blood glucose. If the patient is too altered, they can't swallow or they can't protect their own airway, we don't want to use oral glucose. We can use IV dextrose. We can use some other tools, but oral glucose is great. It's very easy treatment for low blood sugar, and you can always just give the patient orange juice or some other sugary drink as well if that's handy. We do pre-hospital alerts for strokes and sepsis and a lot of other neuro complaints, a lot of other specific conditions. That's very system specific, but it's very important to be well versed in any pre-hospital alert process in a given EMS system. If we encounter a stroke patient, how do we alert the hospital that we're coming in with the stroke patient so they can get all the things together to treat that patient a lot faster? Pre-hospital alerts are very important. They have a very good outcome in our patient condition, especially in rural areas where it takes some time to transport patients. So we want to make sure we're making those pre-hospital alerts appropriately. And then, of course, we treat any and all other findings within our scope of practice. If you find something that you are equipped to treat, go ahead and treat it, right? There's a ton of different causes of altered mentation and neuro complaints in general, and we treat what we can and otherwise support ABCs and get patients to the hospital where they can get taken care of. So the first specific problem we will go over is one that's very important to be well equipped to recognize, and that is a stroke. A stroke is something that occurs when blood supply to a portion of brain tissue is suddenly blocked for one reason or another. The hallmark symptom, the classic symptom of a stroke, is the new onset of one-sided deficits. So facial droop, one-sided weakness, one-sided numbness, anything of that nature. Anything confined to one side should really point us down the route of a patient probably having a stroke. However, that's not the only complaint that should arouse suspicion of a stroke. Really, the new onset of any neuro complaint whatsoever, whether that is dizziness, confusion, a new onset of a headache, any new onset neuro complaint should always arouse suspicion of a stroke, especially if that complaint has a relatively sudden onset, which tells us it's very likely to have occurred due to a stroke. There are two main types of stroke. About 87%, the majority of strokes, are known as ischemic or occlusive strokes. Those occur when blood supply through an artery is blocked for some reason, usually through a blood clot. The other 13% are known as hemorrhagic strokes. Those are brain bleeds when a blood vessel in the brain suddenly ruptures and causes a brain bleed. So we'll isolate those ischemic strokes here. Like I said, these occur when a blood vessel in the brain becomes occluded, right? So a big portion of brain tissue all of a sudden isn't getting a blood supply, so it's not getting oxygen or any other nutrients, and that portion of brain tissue will start to dysfunction and will eventually die if we do not get on top of this problem early enough. A lot of brain cells die every second in a stroke, so it's very important to be timely with our assessment, identify these early, and get them to care early on. There's two main types of ischemic or occlusive strokes. The first is an embolic stroke, and this occurs when a blood clot forms somewhere else and it ends up in the brain. It gets released from some other portion of the body and it finds its way up into the brain in a blood vessel in the brain. This is a very common problem in patients with a history of atrial fibrillation. Patients with a history of AFib, that's an abnormal heart rhythm, they usually take a blood thinner to try to prevent this from happening, but patients with AFib are at a much higher risk of stroke because they tend to form blood clots in their left atrium. If those blood clots break loose, they travel through the left ventricle, they get sent up the aorta, and they get sent right up into a patient's brain, and they can cause a stroke very quickly. The other type of stroke is a thrombotic stroke, and that occurs when a blood clot actually forms in place. So there's a few ways that this can happen. Typically, we will have a plaque. We will have vascular disease in that blood vessel, and that plaque will rupture, and that will lead to a blood clot forming right there in the brain tissue and occluding the blood vessel. That's a very similar pathology to heart attacks. That's how heart attacks typically happen, and that can occur in the brain as well. Embolic strokes tend to result in left-sided deficits simply because those blood clots tend to go up the right side of the brain, and we actually see deficits on the opposite side of the body. Thrombotic strokes can occur on either side of the brain. They really don't discriminate. But the reason left-sided strokes are a little bit more common is because of embolic strokes tending to cause left-sided deficits. The other big type of stroke is a hemorrhagic stroke. This occurs when a blood vessel in the brain ruptures and causes internal bleeding. It causes bleeding inside of the skull. There's two main types of brain bleeds that occur in strokes. There are more types of brain bleeds that occur due to trauma, but when it comes to strokes, the vast majority are either an intracerebral hemorrhage or a subarachnoid hemorrhage. Intracerebral hemorrhage is the most common type of brain bleed, presents as a focal deficit, a one-sided deficit, usually with a headache, oftentimes with high blood pressure, but we have no ability to tell whether it's a brain bleed or a blood clot. We can only identify stroke-like symptoms in the field, but we oftentimes will find out that patients with those focal deficits with a really bad headache and high blood pressure turn out to be an intracerebral hemorrhage. That is bleeding kind of in the meat of the brain tissue. The other type is a subarachnoid hemorrhage, and this is bleeding right on the surface of the brain. These do occur in a lot younger patient populations. This is a very common cause of sudden death in younger people. These happen to 20, 30, and 40-year-olds, right? Whereas most strokes happen to elderly patients, subarachnoid bleeds do oftentimes occur in younger patients, and so it's an important thing to rule out in young adults with altered mental status like we talked about earlier. The typical presentation of a subarachnoid bleed is an initial debilitating headache. The patient will say this is the worst headache they have ever had in their life, oftentimes has a relatively sudden onset. And like I said, this is a common cause of sudden death, so it's something to take very seriously. If you have this suspicion, we should take it seriously. We might want to roll our eyes at a chief complaint of a headache because headaches are common problems that occur every day to a lot of folks, but a sudden debilitating headache is a potentially life-threatening complication and something to take very seriously and consider the possibility of any level of brain bleed, especially subarachnoid hemorrhage in younger patients. The next type of stroke-like symptom is a TIA or a transient ischemic attack. This happens when stroke-like symptoms come and then they go. They disappear and the patient returns to their complete normal self. No way to know if it's a stroke or a TIA in the field, unfortunately, unless those symptoms completely disappear. What this is a temporary occlusion of a blood vessel in the brain. Maybe that vessel is constricted around some vascular disease or something else has happened that has caused temporary occlusion in a blood vessel in the brain. So a portion of brain tissue temporarily does not get a good supply of blood, so it dysfunctions, but eventually that blood vessel relaxes and blood supply is restored and the patient's symptoms go away and they return to their normal. Impossible to differentiate from an actual stroke in the field, so anytime there are stroke-like symptoms, unilateral deficits, new onset neurocomplaints, we always want to treat the patient appropriately and presume that they are having a stroke. And TIAs are also a very strong indicator of a future stroke. Patients with a history of TIAs are much more likely to have an actual stroke in the near future. And just because a patient has had TIAs in the past means nothing about whether a new event is a TIA or not. Patients can have strokes at any time, and we unfortunately have to presume it's a stroke every time we have stroke-like symptoms. Just understand that some patients will turn out to be having TIAs or transient ischemic attacks. So let's dive into our stroke assessment tools. Stroke in EMS is all about assessment. There's nothing that we do in the field that fixes a stroke patient. Our job is to find out that a patient is probably having a stroke so that we can alert the hospital that we're bringing in a stroke patient and get them care a whole lot faster, get them definitive management for that problem a whole lot faster than they would if we did not recognize it in the field. So rapid identification is very important in good patient outcomes. We have very small time windows in stroke where we can get patients care before their brain tissue has completely died. Brain tissue dies pretty darn quick, so we have to get these patients care very quickly if they're going to have good neuro outcomes after their stroke. Otherwise, they're going to have deficits for the rest of their life. Any patient with a neuro complaint should always get a thorough stroke exam. A lot of folks will start with the Cincinnati Stroke Scale. Sometimes that's the only stroke screening tool that EMS providers are taught. And I'm going to try to advocate for a much more broad, much more in-depth stroke assessment tool, because not every stroke is going to show up on a Cincinnati Stroke Scale. A lot of them will not. And we want to identify smaller, more kind of minor presentations of stroke just as often as we identify the big whopping strokes that occur that are very obvious. So in addition to a Cincinnati Stroke Scale or some sort of pre-hospital screening tool, we want to throw in a cranial nerve exam. We'll discuss that in detail, as well as a cerebellar exam, an exam that kind of points us towards problems in the posterior portion of the brain, because those are the most often missed strokes, believe it or not. Always a good idea to involve family in our assessment of a patient when we're doing things like assessing their speech or assessing their walk. Have a family member watch. Have a family member watch every examination that we do, every test we run on the patient, and see if the patient is behaving normally. Because someone who lives with them, someone who is familiar with the patient, is going to be able to recognize when they are acting unusually, and anything like that points us towards strokes, right? Even if it looks normal to us, we don't know that patient. A family member might be able to identify that something is new, something is off for that patient. And then, of course, we get a thorough patient history. We ask about their medical problems. We look at their medical history. We look at their medication list and get as much information about their medical background as we can. So let's talk about some risk factors for stroke. Number one is advanced age, right? Elderly folks have strokes a whole lot more often than young folks, with the exception of those subarachnoid bleeds that are a big killer in young folks, unfortunately. But advanced age is a huge risk factor. Elderly folks do have a lot more strokes than younger people do. Hypertension or high blood pressure is a huge risk factor for strokes, both for occlusive strokes or ischemic strokes and hemorrhagic strokes alike. High blood pressure is a huge risk factor. Prior stroke or TIA, those events are likely to repeat themselves. And remember, TIA is a big predictive indicator of a stroke that is probably going to occur in the future. Then cardiovascular disease, if there are blood clots forming in the heart, if there are plaques forming in the blood vessels in the heart, those are probably forming everywhere, including the brain, and so those patients are predisposed to strokes as well. History of AFib, especially for those embolic strokes we talked about. Patients with AFib tend to form blood clots in their left atrium that get sent on their merry way right up into the patient's brain to cause an occlusive stroke. Diabetes and obesity are risk factors for a ton of medical problems, including stroke. And then family history is key. Patients with a family history of stroke are much more likely to have strokes themselves. So we'll start with our Cincinnati Stroke Scale. This is probably the most common stroke screening tool that we use in the field, definitely the most common one that is taught. This is also sometimes called a FAST exam, not to be confused with an abdominal ultrasound, which is also called a FAST exam, but FAST is a common mnemonic for the things we look for in a Cincinnati stroke screen. There are three things we're looking for here. One of those is facial droop, so we're looking for facial asymmetry. If one side of the patient's facial muscles are limp, they aren't moving, that is a problem that points us towards stroke right away. Arm drift is another one. When we assess for this, it's very important to do it properly. We're going to have the patient hold out their arms with their palms up. The palms up is actually really important because it incorporates a little bit more motor control into the test. Palms down is really poor form. That's not a proper arm drift test. Have the patient hold out their arms with their palms up and hold them there for a good 10-15 seconds. If one arm is obviously weaker and it starts to drift away, that points us towards stroke. Finally, we have slurred speech. A lot of us will have a patient repeat a simple phrase like, "You can't teach an old dog new tricks," or "It's always sunny in Cincinnati." There's a portion of this that shows us the patient can repeat a very simple phrase, and there's a portion of this that shows us if a patient is slurring their speech, which is another thing that points us towards stroke, because if one side of the facial muscles aren't working, the patient's speech will be slurred. And that's a big one to have a family member watch, right? Are they speaking normally? Does their voice sound normal? Does their speech sound normal? Because some folks have a little bit of speech slurring under normal circumstances, so we want to ask a family member, close friend, someone who knows the patient, if their speech seems normal for them. Any single deficit when we do stroke scales points us towards stroke, right? If a patient has facial droop, we automatically assume they're having a stroke. If they have arm drift or slurred speech that seems like a stroke, we assume it's a stroke, right? Very important to understand that. We don't look for any combination of deficits. We don't do any scoring or severity scales in pre-hospital emergency medicine. We're simply identifying if a patient has stroke-like symptoms, and if they do, we assume they're having a stroke. Another common screening tool is the LA Prehospital Stroke Screen. That's just another pre-hospital screening tool that's a little bit more in-depth, but not too much. You can pause the screen and kind of look at some of the criteria in this particular screening tool if you would like to. Just a few additional things like the patient's age, whether they have a history of seizures, which is important information, just making sure we're gathering appropriate information. A little bit more in-depth than a Cincinnati, but in my opinion, we should still go a little bit more in-depth than a simple LA Prehospital Stroke Screen. Another one that's even more in-depth is the MEND exam, or the Miami Emergency Neurological Deficit Checklist. This also goes down exclusion criteria for TPA, which is a clot-busting drug we can talk about. That's a common treatment for strokes inside the hospital. It's great to get the ball rolling and looking for any exclusions, any contraindications for TPA while we're treating the patient in the field, while we have time to gather that information. There's also some additional assessment tools. Notice here we have a mental status exam, a cranial nerve exam like we talked about, and looking for limb weakness, a little bit more in-depth than simple leg or arm drift. And then this also provides a framework for pre-hospital alerts. Any EMS system really should have a framework to alert a hospital that you're bringing in a stroke patient, and criteria to decide whether we're going to bypass the closest ER and take a patient directly to a stroke center. Because it's really important to take patients who are having strokes to appropriate facilities as well. So it's good to know any pre-hospital alerts in your EMS system, because those are things we want to be able to do, because those really make a big difference in our patient's outcome. So we'll dive in depth into a cranial nerve exam here. The cranial nerves are what they sound like. They are nerves that are inside of the cranium going right through the brain, and they control a lot of movement and sensation above the neck. And so when we do a cranial nerve exam, we're generally looking for patients' movements and sensation above the level of the neck. We're looking for one-sided deficits with any of these screening tools. So you can get creative, right? Just remember that we're looking for movement and sensation above the neck, but we'll go over some obvious specific things we can go for. Assess various facial movements, have the patient open their eyes nice and wide, raise their eyebrows, close their eyes nice and tight, give us a nice cheesy smile. We're looking to make sure everything is even on either side. Assess sensation in several places. So feel their face in a few different spots, top to bottom, front to back, and see if it's equal. If the patient says they are numb or tingling on one side, or they have diminished sensation at all on one side, that points us towards strokes. Check for blurry vision in both eyes. If one eye is suddenly blurry, that points us towards stroke. Look for nystagmus, so see if their eyeballs can track your finger without wiggling around, especially when one eye is wiggling around, not tracking appropriately when the other is. That really points us towards stroke. And then assess their mouth and throats for even elevation of the uvula and the soft palate. This is one of my favorite ones because it's one that the patient can't fake and they can't compensate for it. And it's really interesting to see, right? So if you have the patient stick out their tongue and say, "ah," what you should see is the uvula, the famous dangly thing in the back of the patient's throat. You should see that elevate evenly. It should go straight up, and the soft tissue in the back of their throat should go up evenly as well. What happens in strokes, especially big strokes, is that uvula will actually dangle to one side. It'll get pulled to one side or the other, and only one side of the back of the throat, only one side of the soft palate will elevate, and that immediately points us towards stroke as well. Remember, any single unilateral deficit, if it is not normal for the patient, points us towards stroke right away. Even if it is a very subtle sign, a single deficit, right, a little bit of numbness on one side of the face should always point us down the route of a patient potentially having a stroke. Next up is a cerebellum exam. This is one I really like to advocate for because these are the most often missed strokes that we have. Cerebellar strokes or posterior strokes, because the cerebellum is in the back of the brain, they tend to have atypical, they have different chief complaints than your classic stroke. The chief complaint with these is typically a relatively sudden onset of maybe dizziness or vertigo, a balance problem, and a patient just not acting right, not feeling right in their head, especially when that is all of a sudden. Any new onset neurocomplaint, remember, points us down the route of a patient maybe having a stroke. So there are a couple screening tools that are very common for cerebellar exam. One of those is the finger to nose test. When we do that, we have the patient touch their nose with their fingertip. We then have them reach out and touch our finger. There's a couple things we're testing here. The cerebellum is involved in a lot of balance and coordination. So this tests if the patient is able to find their body parts. You should be able to close your eyes and find your nose, find your ears, find your knees. You should be able to find your body parts without having to look at them because you have this internal sense of where your body parts are, and a lot of that happens in the cerebellum. So when a problem happens in the cerebellum, we get discoordinated. You'll find the patient is able to find their nose on one side, or when they use their left finger, they end up poking their eyeball or they poke themselves in the ear or the face. That points us towards stroke. So have the patient touch their nose and then reach out and touch our finger. And then we're incorporating whether or not they can track, whether they have the fine motor control and the coordination to reach out and touch our finger. We have them repeat that, touch your nose, touch my finger, touch your nose, touch my finger, and we move our finger around, do it at least a few different spots on each side, and we're looking to see if both sides of their body work the same, right? If one side struggles, they struggle with their left finger to nose test, but the right goes great. That points us towards a stroke. Another one to incorporate lower extremities is the heel to shin test. What we're looking for, this is tricky in elderly folks, unfortunately, but we're going to have the patient try to take their heel and run it along their opposite shin. So take your right heel, run it up and down your left shin, up your left shin bone. And that tells us more about their coordination and again, whether they can find their body parts without having to look. That one's a little bit tricky in disabled folks and elderly folks in general, but it's one we want to incorporate if we can. Have the patient run their heel along their opposite shin. That's definitely the most common cerebellar exam you find, is the finger to nose and heel to shin test. Those are the best ones to remember if you're only going to remember one screening tool for cerebellar strokes. Another great one is rapid alternating movements. Just have the patient put their right hand over their left hand over their right, and repeat that over and over again. If you see discoordination on one side of the body or just discoordination in general, that's going to point us towards a patient potentially having a cerebellar stroke. Another one is a rebound test. Have the patient pull against your arms and then let go. Seems kind of mean, but we're looking to see if both sides rebound or at least react evenly, right? If one side reacts and one side doesn't, that points us towards stroke. And then a key test to throw in is a walk test, and have a family member or a close friend watch them walk. This is where we find out if they are suddenly walking with a strange gait. The hallmark indication of a cerebellar injury is a wide and unsteady gait, but it really doesn't matter. If the patient is all of a sudden walking different, we should have a suspicion of stroke. And if they're listing to one side, they're walking weird with one leg but not the other, that also points us towards stroke. Again, have a family member, close friend, someone familiar with the patient watch them walk to see if it is their normal walk. So that's your cerebellar exam. Very important to remember to throw that in. We'll talk now about large vessel occlusion stroke and some screening tools that we might have for large vessel occlusion stroke. A large vessel occlusion stroke occurs when a big blood vessel is blocked, maybe an entire carotid artery. So like an entire hemisphere, an entire side of the brain is all of a sudden not getting a good blood supply. These are huge strokes, they are obvious, and we have some screening tools for them because standard of care for treatment is a little bit different depending on the EMS system you respond in. So these are, something like an internal carotid becoming occluded all of a sudden. The CSTAT scale is probably the most common large vessel occlusion stroke screening tool. This is scaled from 0 to 4. 2 or higher is positive, and that indicates a patient is probably having a large vessel occlusion stroke. and we want to treat them and make pre-hospital alerts appropriately. Patients get 2 points for conjugate gaze. That is when a patient's eyes are basically stuck looking to one side or the other. That is called conjugate gaze. It's a very important thing to screen for, and that is immediately positive for large vessel occlusion strokes. A lot of those patients are pretty much unresponsive. They aren't usually alerts. It's usually pretty obvious that they are having a major stroke. Patients get 1 point for arm drift. That's that arm drift test we talked about earlier. Have the patient hold out their arms, palms up, and make sure they can hold them there for a good 10 seconds or so. Patients then get a half a point each for A&O questions and for following simple commands. So if a patient is not alert and oriented, they get a half a point here. If they can't follow simple commands, they can't give you a thumbs up or put 2 fingers up or something like that, they get a half a point. So really when it comes down to it, for a patient being positive for large vessel occlusion, it's either they have conjugate gaze and they're automatically positive, or they have arm drift and they're altered and cannot follow commands, right? Because you need a score of 2 or higher to be positive for large vessel occlusion per the CSTAT scale. Some patients who are CSTAT negative will turn out to be large vessel occlusion stroke, so we can't rule out large vessel occlusion, but we can rule it in. We can have a very good suspicion that a big blood vessel is blocked off and the patient is going to need some pretty significant care to manage that injury. So let's talk about our treatment of strokes. Remember, most of what we do in stroke care is really about assessment. It's about identifying that a patient is having a stroke and making any appropriate pre-hospital alerts, letting the hospital know that we're coming in with a stroke patient so that they can get them care a lot faster. Always prioritize your ABCs. One big consideration with stroke patients is we might want to elevate the head of the bed to prevent aspiration. If a patient is having a stroke and they lose their ability to swallow properly, they can end up aspirating fluids in their mouth. They can aspirate just their own saliva, and that can cause problems down the line, and that's obviously a big risk to their airway and breathing. So consider elevating the head of the bed to make it easier for the patient to breathe if they lose their ability to swallow. And then appropriate oxygen therapy. This is a bit of a controversial topic. Some providers are big on giving oxygen no matter what. Some will tell you that you should only give oxygen if the patient is hypoxemic. So we generally target our oxygen delivery to a saturation between 94 and 99%. If the patient is sitting at 99% on room air, they probably don't need supplemental oxygen, but anything under about 94%, we are going to administer some oxygen therapy to boost them up and make sure they're getting as much oxygen as they can. But when it comes down to it, our big treatment is rapid identification and rapid transport. We call that diesel therapy as a joke sometimes, just rapid transport to a capable facility. When you have a stroke patient who is stable, meaning you can control their airway, they don't have any immediate problem that needs to be addressed in the closest emergency room, we might consider bypassing the closest ER to a capable facility. This is especially important in rural areas. You don't want to take a stroke patient to a facility that doesn't even have a CT scan as kind of a basic rule of thumb, because they can't get any definitive care without a CT scan. So you want to take them to a facility that is actually equipped to handle and receive stroke patients. And so you might consider bypassing the closest ER if you find stroke-like symptoms, again, as long as you're able to assess and secure airway, breathing, and circulation. If they're unstable, they need to be intubated, we're going to go to the closest ER and make sure that happens. And then a pre-hospital alert as appropriate in your EMS system. This is system specific. Some EMS systems have great pre-hospital alert processes. You'll take the patient directly to the CT scan when you make a stroke alert. Sometimes you just show up in the ER and they do their own assessment first. But if we have a pre-hospital alert framework, we want to take advantage of it because that gets our patient care a whole lot faster than they otherwise would. So anytime we identify that a patient might be having a stroke or even have the slightest suspicion that they might turn out to be having a stroke, there's some really important information that we need to gather on them to make sure that the hospital is going to be able to deliver a good level of care. The first is information we should get on every single patient, which is the patient's name and date of birth. But when it comes to stroke care, they actually pull the patient's medical records. They go into national databases and find their medical records and get really important and critical information on them. So name and date of birth is critical. We have to make sure that is their legal name and an accurate date of birth when it comes to stroke patients. It's even more important than it is in an average patient. Next one, which is arguably the most important, is a last seen well that should always be documented in military time. A last seen well is a report from a family member, bystander, someone familiar with the patient who can say this is the time when they were last completely normal. They had no deficits. They were at their baseline, completely normal. You don't want to document that as 1 hour ago, right? And then you have to trace that 1 hour ago. You transport for 20 minutes. Now it's an hour and 20 minutes ago. Always document that as the time it was in military time as soon as you get that information so that it's an accurately documented last seen well, because that's what the hospital is typically going to use to presume when this stroke may have started. Another similar piece of information is a reported symptom onset. Sometimes a patient was found home alone with stroke-like symptoms and they haven't been seen for several days, or sometimes a patient calls 911 because they start to have this blistering headache, the worst headache of their life, and we determine they're having a stroke, but there's no one there to give us a last seen well because they're alone. In those cases, we want to document a reported symptom onset that the hospital might use kind of equivalently to a last seen well. We want a last seen well if it's available, but if we don't get one, we can get a reported symptom onset, which is kind of the patient's report of when their symptoms started, when they started to feel weak, when they started to get a headache, or so on and so forth, when their first neurological symptom that is new started in this particular event. Also document that in military time so that there's no doubt about AM and PM, and document that as the time it occurred. Another critical piece of information is always a blood sugar. You do not want to be that provider that brings in a stroke alert and has it turn out to just be a simple low sugar where the symptoms went away as soon as we gave the patient a little bit of orange juice. We have to get a blood sugar on stroke care. Obviously, low sugars, we're concerned that maybe the symptoms are caused by the blood sugar, and high blood sugars are actually pertinent information in the higher level of care that they're going to get down the line. So we have to make sure we get a blood glucose in every stroke patient, and anyone with altered mental status or a neuro complaint of any kind should always get a blood sugar and a temperature as well, remember. Next one is a list of current blood thinners. Patients typically only take one. Sometimes they will take a couple, but ask the patient if they take any blood thinners, because this means they need more evaluation in the emergency room. They're going to need additional blood work before they can get clot-busting drugs. So it's really important to know if they do take a blood thinner. So make sure you're asking about that. Get contact information whenever possible for a family member, maybe a caregiver, close friend, someone familiar with that patient. There's a couple reasons we want this. One is so that the emergency room can get a little bit of firsthand information. They're going to have questions that we won't have answers to. When it comes to stroke care, it is ABC problems. We gather the critical stroke alert information. But if they're having a stroke, we're not going to spend too much time on scene learning about their entire life story. So we want to bring contact information for someone familiar with the patient so that the providers in the ER, the doctors and nurses there, can get firsthand information from someone familiar with the patient. And another reason we want this, especially if we can get a family member, is because that might become next of kin. That might become the person who is in a position to make decisions for the patient. If they become unresponsive, or they aren't able to make decisions for themselves, we need a family member there to facilitate that decision-making process. So get contact info for a family. Try to bring family members with you if that's appropriate in your scope. We're in the middle of a pandemic while I'm recording this, so that isn't an option. But whenever possible, try to make sure a family member gets to the emergency room early on as well. Another really important one is any medical advance directives. Those are things we always want to get if we have any suspicion that a patient might have them. And it's really just good form to routinely ask about medical advance directives. If a patient doesn't want CPR, if they don't want a feeding tube, they don't want to be intubated, we need to honor those requests, right? Any advance directive that is signed by a physician needs to be respected, it needs to be obtained, and we need to honor those requests that a patient has made because that's what they have requested, right? That is their right. If they do not want a certain level of care, we are not to provide it. So some of these things I will actually write on my glove en route to any sort of neurological complaints that I might be on. I write a last seen well, onset if it's different, blood sugar, and blood thinners, right? Those are critical pieces of information that need to get documented every time. That contact information from a family is extremely helpful for the ER, really good form to make sure we're throwing that in. And then, of course, medical advance directives, because we don't want patients to get treatments that they don't. But this is information to get in the habit of gathering on anyone with a neurological complaint, and definitely get this when it comes to stroke care, because they need most of this information when we make a stroke alert. So we can talk about stroke alerts a little bit here. A lot of EMS systems, probably most EMS systems, are going to have some sort of framework for a pre-hospital alert that you're bringing in a stroke patient. So you're going to call into the hospital and let them know that you are bringing in a stroke patient. All that critical information we gathered on scene is information we want to relay when we are making our stroke alerts. Because that includes the patient's name and date of birth, we should not make these over radio ever, right? We can't relay any protected health information or HIPAA information over the radio. So this is a situation where we typically call into the emergency room on a cell phone or direct landline telephone and relay that information directly and get that stroke alert started so they can start pulling the patient's medical records. They can start preparing to deliver very quick care to that patient. They get a CT scan ready. They let folks know that they're going to need to assess the patient, and they get all those things ready before the patient arrives, which really expedites their care. It's really good for our patients when we can identify strokes and make appropriate pre-hospital alerts, because those just expedite their assessment and their treatment in the emergency room. It's going to notify specialty providers to expect and prepare for that stroke patient. So specialists that might be on a different floor in a hospital are going to come down to the emergency room and be ready to see that patient right away. The lab is going to get notified that they need to do rapid lab work. The folks in the CT scan room, the radiology folks, are going to get notified that they're going to need to prepare a CT scan for the patient. Really expedites definitive care. Sometimes stroke alerts can expedite definitive care by over an hour. Makes a huge difference in our patients, and we want to be well versed and very comfortable in the knowledge of whatever pre-hospital alert process we have in our emergency medical system. Treatments don't happen pre-hospital for strokes. Remember, it's going to happen in the hospital. But I'll cover here just so you can understand what your patients are going to get to treat their stroke. They're immediately going to get some invasive imaging. They're going to get a CAT scan, maybe an MRI, to determine the type of stroke. Is this an ischemic or occlusive stroke, or is this a brain bleed? Because those are treated in completely different ways. We definitely don't want to give clot-busting drugs to a brain bleed because it's going to make it worse. Occlusive strokes typically get TPA, which is a clot-busting drug, tissue plasminogen activator. That is a drug that is designed to bust up clots. It destroys and dissolves clots that have already formed in the patient's brain to restore blood flow in ischemic strokes. In most patients, this has to be given within 3 hours of the onset or 3 hours of the last seen well. In some patients, they can go out to 4.5 hours, and in some patients, in some studies, they are bumping that up a little bit. It's not uncommon to have a protocol that says you should make stroke alerts within the first 6 hours of stroke symptoms. The biggest risk with TPA is uncontrolled bleeding. If you ever encounter a patient who is getting TPA on a transfer or anything like that, they get a nosebleed, they keep that nosebleed until they are off of TPA. They do not form blood clots because it's a drug that's specifically designed to destroy blood clots to restore perfusion to the brain tissue. Another one is PCI, or percutaneous intervention. That is oftentimes the standard of care for those large vessel occlusion strokes we talked about. Patients who are CSTAT positive, they have a CSTAT score of 2 or more, are oftentimes going to get treated with mechanical clot disruption in a cath lab. They will go in, they will suck that clot directly out, they will shoot TPA directly at it. A lot of really interesting things they do to immediately restore blood flow in the cath lab, very similar to how they're going to treat your heart attack patients, your STEMI patients, we call them. They're going to go to a cath lab, or they might go to the operating room and they might actually do surgery to directly remove a clot as well. If surgical intervention is necessary, they will get that. Hopefully they have that available in the center that we take our patient initially. Sometimes surgical intervention requires the patient to be transferred somewhere else. Unfortunately, that leads to very poor neuro outcomes. So whenever possible, we want to take stroke patients to big facilities that can treat any type of stroke. But the bare minimum that I like to kind of recommend is a facility that has a CT scan so they can at least decide whether or not the patient can get tissue plasminogen activator, or TPA. Because they have to determine if it's a brain bleed or a blood clot, right? Because those are treated in pretty much opposite methods. Blood clots get clot-busting drugs. Brain bleeds oftentimes require surgical intervention to get rid of that brain bleed. So the next type of neuro emergencies we'll cover here is going to be seizures. Seizure is kind of a blanket term for when hyperactive brain cells, hyperactive neurons, lead to involuntary motor activity, disrupted sensory perception, altered behavior, loss of consciousness, or maybe all of the above. It's kind of a blanket term for disorganized, chaotic electrical activity occurring in the brain, leading to the symptoms of a seizure. Epilepsy is a relatively common neurocondition that is going to be characterized by frequent seizures. There are a lot of different types of seizures in epilepsy. It isn't the classic tonic-clonic activity in every single patient. and we'll talk about the different types of seizures that are out there. Epilepsy is typically managed with medications to try to keep those seizures under control, or at least to the point where they aren't life-threatening for the patient or occurring so frequently that it really disrupts their quality of life. There's a lot of different types of seizures out there. We're going to talk about some of the more common ones, but anything caused by this hyperactive neuron activity can be classified as a seizure. Two broad classifications to understand are generalized and partial seizures. A generalized seizure affects the entire brain. So we have this chaotic discharge of electricity, of neurons firing when they otherwise shouldn't, throughout the entire brain. Those patients are typically going to be unconscious, unresponsive, and unaware of the fact that they are having a seizure. Partial or focal seizures, on the other hand, only affect one portion of the brain. There's lots of different types of partial or focal seizures that are out there. Some of those patients are pretty well aware that they're having a seizure. They're conscious through the whole thing. Some folks will have impaired awareness during their partial or focal seizures as well. So we'll dive into some really specific seizure presentations, starting with the most common one that we tend to get called for, which is a tonic-clonic seizure. These were formerly known as grand mal seizures, but we have changed the terminology now to tonic-clonic, but both of those terms really refer to the same type of activity. This is the type of seizure activity that most people associate with the word seizure. Usually when someone calls 911 and they say they see someone having a seizure, this is the type of activity that they're observing. Tonic-clonic seizures are generalized seizures, and so they do come with a complete loss of consciousness. The entire brain is suffering from this chaotic discharge of electricity for some reason or another. The terminology refers to a tonic phase of muscle contraction and a clonic phase of shaking or jerking, and patients will go back and forth between these two phases depending on the seizure that they're having, and it will last anything from 30 seconds to several minutes where we have to actually use medications to stop the seizure. This photo does a great job of showing what a lot of folks will experience when they have these types of seizures. A lot of folks will have an aura, a sensation that they are about to have a seizure or probably about to have a seizure, and sometimes that will lead them to call 911 because they feel that they are about to enter a seizure and they need assistance in their home for that seizure. We then have that tonic stage of muscle contraction, of stiffening up, and then a clonic phase of these rhythmic, jerky, contracting type of motions in the body. A lot of those patients will froth at the mouth. They will struggle to maintain the airway, and we'll talk about managing seizures for that purpose as well. And then most patients who have seizures will not come straight back into consciousness. They'll go into this, what we call a postictal stage of kind of disorientation, where they're kind of coming back into it and getting back to 100% consciousness. And we'll talk about that postictal phase shortly here. Absent seizures are another type of generalized seizure that again affect the entire brain, and these are also called petit mal seizures. That's really common trivia, really common test questions to understand that a petit mal seizure and an absent seizure are essentially the exact same thing. These present a little bit differently. There isn't that classic motor activity associated with an absent seizure. It presents as a sudden break in consciousness. So the patient will just simply stare off into space. They will be doing something and they will look like they are just zoning out, but they are actually unconscious during that time when they are staring off into space. Sometimes these are associated with a little bit of clonic activity, a little bit of rhythmic jerking motions, but a lot of the time there's no motor activity whatsoever. The patient just looks like they're zoning out for a little bit. And for that reason, a lot of these get misdiagnosed early on as behavioral disorders, especially in children. If a teacher, for example, notices a child just zoning out to not paying attention, they might misdiagnose them as having a behavioral disorder, as having trouble focusing, rather than having a known seizure disorder where electrical activity is causing this problem. Another type of seizure is a simple partial seizure. So remember, partial or focal seizures only affect one part of the brain. A lot of different presentations here depending on what portion of brain tissue is affected from this disorganized electrical output here. Sometimes patients will get some twitching. Sometimes they will simply experience a strange sensation, a weird taste, weird smell, a shiver going down their neck, something along those lines. And sometimes they can mimic stroke symptoms. It's only affecting one portion of the brain, and so it might cause neurodeficits that only occur on one side. We should always presume the risk of stroke. If a patient looks like they're having a stroke, we don't want to assume that is a seizure unless they have a known history of that specific presentation when they're having a seizure. Next is a complex partial seizure. And a complex partial, once again, it is one portion of the brain, but it's a little bit larger of a portion of the brain than in a simple seizure. The presentation really varies from patient to patient. This is really a blanket type of seizure for disorganized electrical activity happening in a relatively large portion of the brain, but not the entire brain. Some of these patients will feel dazed and confused. They might become unresponsive or have impaired awareness during this time. And a lot of times they will have kind of a near loss of consciousness, but an incomplete loss of consciousness. We call that impaired awareness. Another common type of seizure is a febrile seizure. These are very common pediatric calls, and they're the result of a spike in temperature, hence the term febrile seizure. This is the result of a body temperature that is going so high that it causes this chaotic discharge of electricity in the brain. These are more common in children because children tend to have higher fevers than adults, right? It's not uncommon for kids to be up in the 104, 106 range when they have a nasty infection, and that's the reason that these seizures are more common in kids, just because they have higher fevers on average than adults do. Definitive treatment is really focused on temperature control in this case. We might treat them with our anti-seizure medications, which are usually benzodiazepine medications, but treatment is really there to get the temperature under control. If you administer medications to get that temperature under control, most often just simple Tylenol or acetaminophen, then the seizures will stop because that temperature will come down. Febrile seizures are very seldom life-threatening. They're really not a life-threatening situation in most situations, but we do treat them. We do try to get these under control because it's obviously undesirable for a patient to be having a seizure. So let's go ahead and isolate that post-ictal phase that we kind of touched on. This is a period of altered consciousness and altered mental status following a seizure, following that seizure activity. And this can last a very long time. Patients don't usually have a seizure and then get right back up and get back into their day. They're usually out of it for quite a while. They're in this kind of lucid state for quite a while, over 30 minutes in a lot of patients. When they're in this phase, we want to stay with them and we want to allow them some nice space, a little bit of peace and some space to recover and get back into it, right? And always prepare for the potential for additional seizures during that phase. If we have another seizure, we're then going to have to manage the patient once again. Let's talk about a really important topic, which is Todd's paralysis here. Some patients, for some reason, they will have a seizure, and then after their seizure, they will experience one-sided weakness for a considerable amount of time. Remember, any one-sided neurodeficit should always point us towards stroke, and we should always presume they're having a stroke unless we know they have a history of this specific presentation, because we don't want to miss a stroke and assume it was caused by a seizure, because it can go both ways. A stroke can lead to a seizure, and a seizure can lead to those unilateral deficits that look like stroke symptoms. So always maintain a suspicion unless they have a known history of something called Todd's paralysis. If a patient wakes up from their seizure and they tell you that, yes, I always feel weak on my left side for a few hours after my seizure, that is one thing. But if a patient has the first seizure of their life and they're all of a sudden weak on one side, we should generally presume that that is a stroke. All right, a stroke can lead to a seizure, just like a seizure can lead to stroke-like symptoms. We should always presume the worst-case scenario whenever possible. So now we can talk broadly about pseudo-seizures. There's a lot of different terminology that we can use to describe seizure-like activity that isn't actually a seizure. It isn't actually this chaotic, overwhelming discharge of electricity in the brain. A lot of patients will have some sort of convulsion, some motor activity that might look like a seizure but isn't related to a seizure. They might have some muscle spasms. They might have jerky movements for one reason or another that isn't caused by a seizure. And then there's a classification of seizures referred to as psychogenic non-epileptic seizures. It's important to understand that these patients are not necessarily faking. That is unfortunately something that will occur. Patients will pretend to have seizures for one reason or another, but we should never assume that is the case. Psychogenic non-epileptic seizures are a class of seizures that are well researched, that are diagnosed, where patients will have seizure-like activity even though they aren't actually having a seizure in the sense that they have this disorganized electrical activity happening in the brain. Always assume that seizure activity is involuntary. We never want to do rude things. You may get taught by folks in EMS to put a non-rebreather mask on a patient and use ammonia inhalants to try to trick them, right? To try to force them out of their fake seizure. But those are very aggressive. We never really want to do that. We want to presume the activity is involuntary. We don't want to treat our patients like they are faking. We always want to make sure that we are treating the patient as if they were having a seizure and assume that that activity is involuntary. When we see this type of activity, when we see seizure-like activity in a patient who isn't having a seizure, for example, someone showing tonic-clonic type motor activity, but they're tracking us with their eyes, they're clearly conscious, it really comes down to communication and appropriate treatment, right? Communicate with the patient, let them know that you are there to help them, and use whatever treatments are appropriate within your protocols and your scope of practice. So let's talk about our assessment of seizure patients here, right? We talked about some of those common presentations of seizure. There's a lot of different seizure types that can occur out there. Those are very broad classifications that we went over. Want to know if a patient has a history of prior seizures. That's very early information we want to get. If a patient has epilepsy, it's probably not very concerning that they're having a seizure. We will treat the seizure, but it really doesn't concern us that they are having one, right? Because seizures are relatively normal for the patient versus a patient who might be having a seizure in response to head trauma, where that's a life-threatening problem in and of itself. We want to get information about the nature of the seizure. So are we seeing motor activity, like classic tonic-clonic motor activity? Is the patient conscious during the seizure? And how long are the seizures lasting, and how many of them have they had, right? We do not like to see patients having seizure after seizure, and we don't like seizures to last anything over more than about 5 minutes. That really gets us nervous. That's where some damage can actually happen to the brain, where we're going to need to intervene and try to stop that seizure as best we can. We want to know if the patient was incontinent during the seizure. That tells us if their seizure was bad enough to result in incontinence. Doesn't give you a ton of information about how bad the seizure was, but it is an important thing to assess for. We want to know about that post-ictal state. Did they come out of this seizure-like activity and then instantly return to consciousness? Or are they in a post-ictal state for a while? Or are they a little bit lucid, a little bit out of it for a period of time after their seizure, which is pretty common, and that's to be expected. We then, of course, do a full assessment, full vital signs, including an EKG in most folks, where there's any suspicion of a heart problem or any seizure of unknown cause. Patient always gets an EKG and a full set of vital signs, including a blood sugar and a temperature, to rule out a blood sugar problem and the possibility of a febrile seizure. Our treatment of seizures is relatively straightforward. We don't always have to do a ton of invasive treatments for seizure patients. Remember, folks with epilepsy have seizures on a regular basis. They typically don't call 911 until those seizures have just lasted too long of a period of time, and usually their physician has told them to call 911 or told their family member to call 911 if a seizure lasts for a certain period of time. Our number one priority, as always, is the patient's airway. So we want to support that patient's airway. In that tonic-clonic motor activity, a lot of times we get frothing in the mouth, we get a lot of saliva, and that comes with a risk of aspiration and airway compromise. Very important that we don't ever place anything in the mouth of a seizure patient. We don't do bite blocks anymore, and anything that goes in between the teeth is out the window. We are not going to place anything in between the patient's teeth. We are going to position them on their side to protect their airway, to make sure any contents, any saliva, any frothing in there doesn't go in their airway but falls out onto the floor. And you might consider a nasopharyngeal airway. We can't use an OPA or an ET tube or King tube, anything like that, because we don't want to put anything between the teeth, but we can insert an airway through their nose, and that is a great move, especially for prolonged seizures, where we might start having to intervene in ventilatory management and things like that. We can also use aggressive suction. You might be able to use that tonsil tip on the outsides of the patient's teeth, your hard suction catheter outside your patient's teeth, but not even a suction catheter should go in between the patient's teeth. And definitely do not put your fingers there, because the patient will bite down on them, unfortunately. We can suction through a nasopharyngeal airway. We can suction on the sides of the teeth, but the bottom line is we don't place anything in between the teeth of a patient who is having a seizure. Definitely consider supplemental oxygen. It is absolutely appropriate to put a non-rebreather mask by default on a patient having a seizure, because they don't typically breathe adequately. They will usually breathe enough to keep themselves alive, but their breathing isn't necessarily adequate, and it's 100% appropriate to administer supplemental oxygen while a patient is having a seizure to prevent hypoxemia. We want to make sure we get in a blood sugar, right? That's a very important vital sign. Low blood sugars can cause seizures. Seizures can also deplete enough glucose to result in a low blood sugar. So it's very important to get a sugar on anything seizure related. And remember, we always get a blood sugar on anything mental status related. Any neuro complaints, we always get a blood sugar. If medications are necessary to stop a seizure, that is an advanced life support problem. Advanced life support resources, paramedics, and higher level EMTs can administer benzodiazepines, which are the main class of drug that we use to treat seizures. Those are drugs like Ativan and Versed, otherwise known as midazolam. We administer benzodiazepines to get that seizure activity to stop if it does not stop on its own. So let's talk about transports here. Remember, seizures are very common for patients with epilepsy. They don't necessarily want to go to the emergency room. Sometimes you will encounter a patient with epilepsy who was out with a friend who was unfamiliar with their condition, and so they called 911 even though the seizure wasn't very long. We arrive, and the patient is already consciousness, and maybe they don't want to visit the ER, and it's always the patient's right. But there are certain situations where we want to strongly encourage transport. We are in the business of always encouraging transport, but in some of these things, we really want to push for that, and we want to explain to the patient why. One of those is a first-time seizure or an unknown cause, right? A patient who doesn't have a known seizure disorder, we want to take those seizures seriously. That could be an indication of some brain injury that has occurred. That can be an indication that they're growing a brain tumor. That can be the new onset of a neuro problem. But those patients need to get evaluated in the emergency room anytime it's a first-time seizure or a seizure where we don't know what caused that seizure otherwise. Any prolonged seizure over about 5 minutes or any seizures that occur back-to-back are seizures that should be transported to the emergency room, right? Seizures shouldn't be lasting that long. They shouldn't be lasting more than a few minutes. Anything over about 5 minutes, we definitely want to get the patient evaluated so they can take a second look at their medications and make sure they are in a place where they are safe if they have another seizure, where they can be treated for those seizures early on. Next is injured patients. If a patient has hurt themselves in their seizure, understand a patient who suddenly has a seizure might fall straight to the ground, they might hit their head, they might break a bone, and otherwise hurt themselves. Those patients should always go to the ER to get evaluated for the injuries. Any difficulty breathing, any ABC problem that exists, we're always going to push transport. We're always going to treat them appropriately. And then any patients with major health problems, if they have big problems with their heart, any known, major neuro disorder where seizures aren't common but have occurred secondary to a health problem, we want to take those patients to the ER. So any high-risk patient in general, always push transport. Again, we really should push transport anytime, but a patient with a seizure disorder who has a normal seizure probably isn't going to want to visit to the emergency room. But when that isn't the case, when they don't have a seizure disorder, we should always get them evaluated so we can figure out what happened. So next we'll go ahead and talk just a little bit about headaches. Headaches are obviously a relatively common complaint. A lot of folks will experience headaches on a regular basis and probably don't call 911 for minor headaches, but sometimes patients will have a headache that is bad enough that it leads them to call 911. And remember, anytime a patient calls 911, no matter how silly that complaint might sound, that is an emergency at least to them. And if a patient has a headache that is so bad that it leads them to call 911, we want to presume there is a life-threatening emergency. We want to consider life-threatening emergencies first when we assess patients who are having headaches. First on that list is going to be a stroke. Headache is a very common chief complaint in stroke patients, and we want to do a full stroke exam anytime a headache prompts a 911 call. Traumatic brain injury is another really important thing to rule out or at least assess for. Ask the patient if they have had any falls recently, have they hit their head, do they take any blood thinners that might predispose them to traumatic brain injuries or to brain bleeds secondary to trauma. Another really big one is a hypertensive crisis. Sometimes you will get these headache complaints and you will get a blood pressure that is well over 200 systolic, and that is a life-threatening emergency. The heart cannot sustain that type of blood pressure. It can't move blood against that enormous of a blood pressure, and that is an immediately life-threatening emergency. There's a lot of different types of headache out there. We'll go over some of the more common ones. Just remember, anytime you get a 911 call for a headache, the big things you want to think about are things like stroke and traumatic brain injuries and potentially a hypertensive crisis. You want to think about life-threatening emergencies first and rule those in, or at least assess for any signs and symptoms of those life-threatening emergencies first. So we'll cover those life threats starting with stroke. Anytime a patient says they're having the worst headache of their life, or they're having a headache with other neuro complaints, that should immediately arouse suspicion of stroke, right? Any severe headache to begin with, especially if it's a relatively sudden onset or it's a new headache, right? They've never experienced that feeling of a headache before. We want to point ourselves towards stroke, and we want to do a thorough stroke exam to assess for any signs and symptoms of a stroke and consider pre-hospital alerts if we find signs of a stroke. Next is a brain injury, right? Ask about recent falls, recent head trauma. Ask if the patient takes any blood thinners that would predispose them to worsening brain injuries. And again, hypertensive crisis. A critically high blood pressure will result in a blistering headache that might result in a 911 call. And if they have that super high blood pressure, that is an immediately life-threatening emergency. So we'll talk about some of the common headache types here, starting with migraines. Migraines typically present as a really severe and throbbing pain. A lot of times they come with a sensitivity to light and noise. A lot of folks who have migraines do not want to see lights. They want to get in their room where it is dark, where there is no noise, where they can relax and get that sensory stimulation taken away. Migraines may be localized to one side. A lot of times those are called hemiplegic migraines, and that's another thing that can kind of mimic stroke-like symptoms. Remember, any one-sided deficits that aren't normal for the patient, that haven't been experienced before and are diagnosed as something that isn't a stroke, we should always presume that one-sided deficits are a stroke if there is any doubt in our minds. Some patients will experience an aura, kind of like seizure patients experience an aura when their seizure is going to happen. Some folks who have migraines will experience an aura before their migraine headache. A lot of times this is also accompanied by nausea and extreme fatigue. Migraines do have to be diagnosed by a physician. We can't just say a patient is having a migraine because they're having a severe throbbing type of headache, because we can't diagnose in the field, right? We can't rule out the possibility of a brain bleed. We can't do a CT scan of their head in the field. At least not yet, right? That might be in the future, but we can't do that yet. So migraine headaches are something that has to be diagnosed by a physician, and that is something to kind of politely ask your patient. If they tell you they're having a migraine headache, ask them if that's migraine that has been diagnosed by a physician, or if they're just calling it a migraine because it seems like it's a migraine headache based on their knowledge of what a migraine headache is. Again, always assume it's a stroke. If it seems like a stroke, err on the side of caution and treat the patient appropriately. Migraine headaches are diagnosed by a physician and are typically normal for the patient. When they experience migraine headaches, they experience headaches that are largely normal for them, and they will tell you that this is a similar presentation to their migraines in the past. Next type of headache is a tension headache. This is a very common type of headache. It is what a lot of people associate just with your average headache, where you go and you take some over-the-counter medications to treat that headache. It's a dull pain across the forehead, neck, and back of the head. Patients might experience a sensation of pressure inside their head. It's oftentimes accompanied by fatigue and sometimes a lack of sleep as what leads to headaches. There's a lot of things that can cause an average everyday headache. Most tension headaches are going to be relieved with NSAIDs, with acetaminophen or ibuprofen or some sort of over-the-counter remedy for minor pain control. Sometimes an ice pack or warm sensation on the head helps really well. Temple massage works really well. Tension headaches are relatively common out in the world, and most folks don't call 911 for your average tension headache unless it's bad enough. Next is a sinus headache, and hence the term. This is pain kind of around these sinuses, around the bridge of the nose, on kind of the front of the face. Typically in a sinus headache, if we apply pressure, that can make the pain a lot worse because we're applying pressure to those sinuses that are hurting in this case. It's oftentimes associated with nasal congestion or some sort of sinus infection or upper respiratory infection. And once again, they're typically well controlled with non-steroidal anti-inflammatory drugs or NSAIDs and nasal decongestants if there's nasal congestion taking place. It's another one where patients don't typically call 911 for a sinus type of headache. Another potential presentation is known as a cluster headache. These are oftentimes the most painful type of headache that is imaginable for a patient. Patients who have these will get frequent bouts of short duration, excruciating headaches that obviously aren't very fun, aren't very desirable for the patients who have them. These are almost always one-sided, and once again here, when we're dealing with any doubt, we want to presume that the patient is having a stroke. Unless this is diagnosed, right, unless this is normal for the patient, it has happened before and been diagnosed as a headache, we want to maintain suspicion that this patient is having a life-threatening emergency like a stroke, because any one-sided neurocomplaint should always point us towards stroke, should always arouse suspicion of stroke. Cluster headaches are another one that has to be diagnosed by a physician. So once again, we want to politely ask our patients if they have been diagnosed with cluster headaches. If they tell us they're having cluster headaches, we want to know if that is actually diagnosed by a physician as something that occurs to this patient, or if that's something they're basing off of what they've read on the internet, which is usually accurate in their defense, but a true diagnosis of cluster headaches has to come from a physician, and it can't come from us as well. Symptom control for these is a little bit more complicated. These aren't always relieved with simple over-the-counter medications, and so treatment can get a little bit more complicated and really has to be driven from a patient's physician. Treatment of headaches really kind of depends on what we think is causing that headache. We always need to perform a thorough assessment. We need to do a complete stroke exam. We need to do the best stroke exam that we would do on a patient where we really thought they were having a stroke. Any complaints of a headache should earn a very thorough neuro and very thorough stroke examination. And treatment's really going to depend on your scope. Obviously, if we presume the patient is having a stroke, if we have one-sided deficits that aren't normal, we want to treat the patient appropriately, right? Make appropriate pre-hospital alerts if that's what you do in your EMS system. Just very important to follow your own local protocols when it comes to those things. As far as treating the actual headache, ice and hot packs are usually a great move. Those will do a lot of good for patients, right? Just the sensation of hot or cold will help get rid of a little bit of pain. Environmental control is big, especially folks who have migraines. Keeping the lights dim, right? Keeping it dark, reducing any outside unnecessary stimulation usually does good things for the patient, usually makes them more comfortable. NSAIDs might be in your scope of practice, or other pain medications might be in your scope of practice, or they might not. Once again, just follow your own local written protocols. And then any various comfort measures. If there's a position that is more comfortable for the patient, that is great. If they want to be lying down versus sitting up, whatever makes the patient more comfortable is how we should go about this, right? Ice and hot packs, keeping outside stimulation to a minimum, whatever medication we can give in our scope, and just whatever we can do to make the patient feel more comfortable. So next we'll go ahead and dive into the realm of dementia. Now, dementia is a very general term for loss of memory and other mental capabilities, very general cognitive decline that tends to occur with age, but occurs with very specific neurological disorders as well. This leads to a major disruption in a patient's quality of life, and it does complicate our assessment of a patient for any complaint they may have, because folks with dementia do not necessarily relay pertinent or accurate information to us, and we can otherwise refer to them as unreliable historians, especially in advanced dementia, and we have to rely on family members, caregivers, and other folks who are familiar with the patient to gain a complete and accurate history in a lot of cases. There are a lot of specific types and causes of dementia to be aware of. The most common one is Alzheimer's disease, but not every patient with dementia is diagnosed with Alzheimer's disease specifically. There are quite a few others. There's frontotemporal dementia, otherwise known as Pick's disease. There's Huntington's disease. There's Creutzfeldt-Jakob disease, Wernicke's encephalopathy, Parkinson's. A lot of specific causes of dementia out there, and this isn't an exhaustive list by any means because dementia is a very general term. It's a blanket term for that type of cognitive decline that occurs with these conditions. We'll go ahead and talk about some specific causes of dementia here, starting with Alzheimer's disease. This is the most common cause of dementia. Somewhere between 60 and 80% of patients with dementia are diagnosed with Alzheimer's specifically. The cause of Alzheimer's disease is unwanted biochemistry, unwanted protein formations in the brain that lead to this neurological decline. Specifically, those are referred to as amyloid plaques and tau tangles. Neither of those are specific to Alzheimer's disease. We see those formations in other disease processes, but the ratio, the parts of the brain where they form, lead to Alzheimer's disease specifically. Alzheimer's usually affects elderly populations over about age 65, but early onset Alzheimer's does occur in younger populations as well. It's just a lot less common. The most common symptom of Alzheimer's disease is going to be difficulty in remembering new information. The most common medication you will see on a med list is going to be donepezil, otherwise known as Aricept, in addition to other medications they might take, but this is the most common medication used to treat dementia. The intent of that medication is to slow cognitive decline over a long period of time. It isn't there for any acute symptoms in most cases, and if a patient has donepezil on their med list, the chances are they have a diagnosis of some sort of dementia, and potentially Alzheimer's specifically, if for whatever reason that history is not clear through other areas of your assessment. So another potential cause of dementia is something known as frontotemporal dementia, or FTD. And this is a disease that affects the front portion of brain. Frontotemporal refers to the frontal and temporal lobes of the brain, where we typically have the most decline. We have the most disease occurring in that front portion of the brain. This term is often used interchangeably with Pick's disease, which is actually a very specific cause of frontotemporal dementia, very specific presentation, but a lot of textbooks, a lot of resources will use these terms interchangeably. FTD is caused by tau tangles, very similar to the tangles we see in Alzheimer's, and another really specific protein that leads to basically unwanted biochemistry occurring in the front portion of the brain that causes the neurological decline. There's a lot of subtypes of frontotemporal dementia. There is a behavioral variance, there is progressive aphasia, and various motor function diseases that are in the category of frontotemporal dementia. This one does tend to come with a lot of behavioral effects. Unfortunately, folks will struggle with aggression and some undesirable emotional responses when they have that diagnosis of frontotemporal dementia. Another one to be aware of is Huntington's disease. This is a progressive brain disorder that has a genetic background to it. It's caused by a defective gene. Onset of Huntington's disease is typically somewhere between age 30 and 50. The result is uncontrolled, unwanted body movements and a decline in thinking and reasoning skills and those symptoms of dementia. That's why we have it as a potential cause of dementia or dementia-like symptoms. Treatment in Huntington's over a long term is really focused on controlling symptoms and improving the patient's quality of life as best we can, because unfortunately it is a progressive disorder with no cure. Next is Creutzfeldt-Jakob disease, or CJD. This is a fatal brain disorder, unfortunately, and it is in the prion disease family. Prion proteins are normal, but in a disease process like CJD, they fold into a pathologic, a problematic shape that leads to the neurological decline. CJD does come with a relatively rapid progression of symptoms, and it has a lot of similarities to other prion diseases like mad cow disease and chronic wasting disease that we might see in game animals, if you are familiar with those. Sometimes CJD is genetic, but it can also occur sporadically. It occurs with no known cause, which is very unfortunate, but it is a relatively quick progressing fatal brain disorder that we may encounter. Wernicke or Wernicke's encephalopathy is another potential cause of dementia-like symptoms. This is a neurological disease that is simply caused by a thiamine deficiency. It's going to be associated with nystagmus, ataxia, and confusion, and it is almost always associated with chronic alcoholism. Alcoholism is what leads to the deficiency of thiamine, which leads to a secondary encephalopathy that leads to the neurological decline here. We typically have dementia-like symptoms with altered mental status and cerebellar dysfunction. Remember, the cerebellum is in the posterior portion of the brain. It affects a lot of balance and coordination functions. Treatment for this is typically aimed at correcting the thiamine problem. If we can correct the thiamine deficiency, we can hopefully reverse the encephalopathy and get the patient back to normal. And then, of course, if the patient is struggling with chronic alcoholism, they're going to receive treatment for their alcoholism as well. Alcoholism is a relatively common cause of thiamine deficiencies. Next one we'll cover here is Parkinson's disease. This is definitely one to understand at least just the basic background, because it is relatively common out there in the field. This is a neurological disorder, and it is caused by what we call Lewy body deposits in the brain. And you will hear this called Lewy body dementia as well. It's kind of an older, different term that you might hear. It affects about 2% of adults over age 65. That actually comes out to quite a few adults. This is a relatively common cause of dementia that you will encounter out there in the field. Early symptoms of Parkinson's disease include tremors, shaking, muscle stiffness, and a stooped posture. The tremors are usually the most apparent, the most obvious symptom that we can see. This eventually leads to problems with memory and mental function and leads to cognitive decline, and that's why it is a cause of dementia and dementia-like symptoms. Treatment for Parkinson's is, again, based on symptoms. There's no definitive cure for Parkinson's, just like Huntington's disease. So treatment is there for symptom control, to control those tremors, to control any pain, and to improve the patient's quality of life as best we can while they're going through this. So we can talk about broad treatments for dementia. There's nothing we can really do to fix dementia in the field. Unfortunately, we can't reverse neurological decline. If we would, patients probably wouldn't have dementia anymore. So we always default to the ABC problems. We make sure we assess and support the airway, breathing, and circulation as best we can within our scope of practice. A big assessment tool with these patients is just including caregivers, family members, folks who are otherwise familiar with the patient, and they know what is normal and what is not normal for those patients. And that information is very valuable, is information that we want to gather when we're with those people who are on scene, hopefully with our patient. We want to perform thorough assessments, as obviously these patients aren't going to be able to relay pertinent details. If a patient with dementia is encountering a cardiac problem, they can't be expected to experience chest pain. So we have to do very thorough assessments on these patients when things are going wrong to get to the bottom of what might be causing their problems, whether that is a neurological emergency or whether they're having a presentation of chest pain or a bad blood pressure or anything under the sun. Make sure we get any advanced directives, any DNR orders or medical advanced directives on these patients, because if they don't want CPR, we want to make sure that we aren't going to have to perform CPR in them or any other advanced interventions that they might not want. We want to make sure we obtain and we honor those advanced directives, because a lot of patients with a history of dementia do not want to be resuscitated. They do not want a feeding tube. They don't want to be intubated. And we want to make sure we honor those wishes of the patient, and that requires us to obtain that paperwork and make sure we're following the orders that have been written and signed for that patient. We can help patients out a little bit by controlling the environments. This really just helps improve trust and improve the patient's comfort with the situation that they're in, and make it a little bit more pleasant for them to be transported into the emergency room. So we want to limit unnecessary noise. We want to limit any sort of distractions for these patients. We generally want to keep lights nice and bright for dementia patients so they can see their surroundings. Folks do tend to get uncomfortable in dimly lit environments because they get confused when they can't see their surroundings. And just generally speak softly and calmly. That is good form for all patient contacts, but especially true for folks who are suffering from dementia or some level of cognitive decline. Physical contact is usually comforting for dementia patients. If you need to direct folks towards your cot, you can kind of hold their shoulder and point them in the direction they want to go. This is a population where firm touch, secure contact usually does help build trust with your patient and improves your patient's comfort level, really. Very important when we're treating dementia patients that we don't just assume that neurological decline, that altered mental status is just because of their dementia. If family members on scene are saying the patient is acting abnormally, we want to assume they are acting abnormally, that they do have acutely altered mental status, even with a background of dementia. So we've got to consider those other causes, right? Look for any signs and symptoms of infection, that really common cause of altered mentation in elderly folks. Look for signs and symptoms of stroke or any other potential cause of altered mental status. And again, make sure we are doing thorough assessments because the patient can't necessarily relay information. So we've got to do as thorough of an assessment as we can to find any problems that are there to be fixed. So now we can talk about some more just broad miscellaneous neurological disorders that you might encounter. This isn't an exhaustive list. We couldn't possibly cover every neurological disorder that exists. We're just going to cover some of the potentially more common ones that you might find out there. One of those is hydrocephalus, that occurs when cerebrospinal fluid accumulates in excess inside the brain, and we'll touch on that in detail in a couple slides here. Tumors and cancer, right? Brain tumors, brain cancer can obviously lead to neurological emergencies. Those can lead to seizures, to stroke-like symptoms, to an increase in intracranial pressure, simply because we have an unwanted growth occurring inside the brain. Demyelinating neurological disorders are a broad class of neurodisorders that include one that a lot of folks are familiar with, which is multiple sclerosis, or MS, and another one you might have heard about is Guillain-Barré syndrome. Infections are a big potential cause of altered mental status, whether that is a systemic infection that is leading to altered mentation, or if that is an infection of the brain itself, something like encephalitis or meningitis, because those conditions can become life-threatening very quickly. And then cranial nerve disorders are a very broad category of disorders that, hence the name, refer to problems that affect the cranial nerve. So we can touch on hydrocephalus in a little bit more detail here. Hydrocephalus occurs when we have an abnormal and unwanted buildup of cerebrospinal fluid in the ventricles of the brain. The ventricles are basically just storage units for cerebrospinal fluid. So basically what we have is a lack of proper cerebrospinal fluid drainage to the point where it accumulates in excess and starts to place a pressure on the brain tissue. Remember, any increase in pressure inside the brain can't go anywhere. The cranium is a rigid structure. It's not going to expand. And so when we have an increase in pressure inside the skull, that pressure just gets placed on the brain tissue and can cause a lot of neurological symptoms there. This condition can be congenital in some cases. It might be acquired through disease, and sometimes it just occurs spontaneously, and we don't really know why. This is visibly obvious in infants because infants don't have fully formed skulls yet, so their skulls will swell, and so they have a very enlarged head, and it is very obvious when an infant is potentially suffering from hydrocephalus. The symptoms we're going to find are going to be altered mental status and potentially an increase in intracranial pressure, maybe impaired cognition, a headache, seizures, any other neurologic complaints, right? What we have is a pressure on the brain tissue, so neuro complaints of any kind can really be the result of this increase in intracranial pressure. Remember, cerebrospinal fluid is something that we need. It supports and nourishes the brain, but when it accumulates in excess here, we start to have a really big problem. Hydrocephalus is typically treated and managed very successfully with something called a ventricular shunt. Another term you might hear is a cerebrospinal fluid shunt. Sometimes it is nicknamed as kind of a slang as a brain drain. But that is a shunt, that is a catheter placed into those ventricles of the brain to allow excess cerebrospinal fluid to drain off. This is placed surgically. This is a relatively common surgical procedure these days. We have a catheter, we have some sort of valve to make sure there is enough cerebrospinal fluid in the brain, but to allow anything excess, any extra pressure to drip off, and it typically flows in either to the right atrium or into the abdominal cavity, where that extra cerebrospinal fluid will be allowed to drain. If those catheters become dislodged, a patient who has a history of hydrocephalus can all of a sudden start to have life-threatening symptoms again. So they can have an elevation of intracranial pressure and associated signs and symptoms. They can have acutely altered mentation and a whole number of different neurological complaints that are related to the pressure being placed on their brain in that case. So if you have a patient with this history and something has gone wrong with it, we can oftentimes see these symptoms that are related to their hydrocephalus and the lack of proper cerebrospinal fluid drainage from their brain. We'll review Cushing's triad briefly, or maybe introduce Cushing's triad if you have not heard it, but Cushing's triad is a set of clinical symptoms that are associated with a really critical increase in intracranial pressure. The first two symptoms are also known as Cushing's reflex, and those are hypertension, high blood pressure, and bradycardia, or a slow heart rate. The combination of high blood pressure and slow heart rate oftentimes points us to a neurological problem, or at least increases our suspicion of a neurological problem. The third symptom of Cushing's triad is irregular respiration, as this is the result of pressure being placed on the brainstem, which is our respiratory control center, and so we get irregular respirations in response to that. Irregular respirations are a very critical sign that tells us the patient's brain is about to herniate, their brainstem is about to be squished out of the skull, and that is a life-threatening condition. Another kind of miscellaneous neurodisease to be aware of is multiple sclerosis, or MS. This is a chronic autoimmune disease of the central nervous system. About 400,000 patients in the United States. Not a ton of them, but I'm sure you will encounter a patient with MS at some point in your career. The symptoms of MS are things like vertigo and an unsteady gait, vision dysfunction, tremors, weakness, fatigue, cognitive decline, and chronic pain. This is a very well-established disease process that is known as multiple sclerosis. Absolutely something that's worth doing a little bit of extra research on if you're interested in learning more about it. So next we will talk a little bit about meningitis. Meningitis refers to inflammation of the meninges. Anytime you see that suffix itis, it is referring to inflammation, and in this case it's referring to inflammation of the meninges. The meninges are a few different layers really of brain covering that sit in between the brain and the skull bones that you see there. The photo does a really great job of showing the meninges and the different layers within. This inflammation is typically the result of some sort of an infection that can be a bacterial, viral, fungal, or parasitic infection. The most concerning in most cases is bacterial meningitis, which comes with a pretty high fatality rate of about 14%. We see a lot of undesirable outcomes in bacterial meningitis. Any kind of meningitis is concerning though, because it's dealing with the patient's brain. The typical signs and symptoms for meningitis are going to be a headache, stiff neck, and light sensitivity. We refer to those oftentimes as meningeal symptoms. Also goes with a fever secondary to the infection, and typically lethargy, altered mentation, and various neurological symptoms because we are dealing with the brain. We're dealing with very sensitive real estate when we have an infection in the brain covering there. An old school assessment strategy that you might get taught to do is to have the patient touch their chin to the chest. That isn't routinely recommended anymore. It's not really specific for meningitis, and it doesn't gain any good information. And in rare cases, that can actually cause some untoward effects, some undesirable effects on our patients. So we don't necessarily need to do that. It's probably not going to harm them, but it's not a very specific assessment strategy to identify meningitis. We can't really diagnose this in the field. We can have a suspicion. Anytime you have a patient who looks like they have an infection and they have these kind of meningeal symptoms, they have a really bad headache with a stiff neck and sensitivity to lights, we want to have a high suspicion of meningitis or something similar going wrong with the patient's brain. So next we'll touch just briefly on cranial nerve disorders, which are another one of those kind of broad categories of neurodisorders that you might encounter out there in the field. Remember, we talked about cranial nerves when we talked about strokes and a cranial nerve exam, and we said that these tend to control sensation and movement above the neck. And so those are the abnormalities that we tend to see. There are a lot of different cranial nerve disorders. The specific signs and symptoms of each one is going to depend on which cranial nerve or nerves are affected in that particular disease process. There's a lot of conditions that are relatively well-defined, well-researched that you might encounter in the field. This is a short list that you see on the slide here. There are more cranial nerve disorders, and the symptoms that we find all just depend on the specific nerves that are affected in a given disorder. We can take a look at the kind of anatomy of our cranial nerves here, which might help you to understand what we're doing in a cranial nerve exam and help you understand really what cranial nerves are. We have 12 pairs of cranial nerves in a human brain. Nerves 1 and 2 arise from the cerebrum, which is kind of the meat of the brain tissue, for lack of a better term. Nerves 3 through 12 arise from the brainstem and then travel wherever they need to go. One of the most important ones for us to know is cranial nerve 10, which is also known as the vagus nerve, and that plays a critical role in a lot of parasympathetic, or those rest and digest type of responses. Vagal stimulation can cause a decrease in heart rate. It can cause other parasympathetic responses that are very important. And so the vagus nerve, just always remember that it relates to the parasympathetic nervous system. If we say we're getting vagal stimulation or we're trying vagal maneuvers, the goal is to activate the parasympathetic side of our nervous system. It plays a critical role in maintenance of a patient's heart rate, among a lot of other things. So notice how these cranial nerves are located in various places in the brain. That's kind of why we do a cranial nerve exam in stroke care, because we can find different pieces of brain tissue that might be underperfused. If they're cutting off perfusion to a given nerve, whether that's at the base of the nerve or somewhere along its pathway, and they're located all over the brain. Most of them arise from the brainstem, but cranial nerves 1 and 2 do arise from the cerebrum, which is, like I said, the kind of meat of the brain tissue, for lack of a better term. You can take a look at the photo there to see each one of those nerves. Most important to remember is going to be your vagus nerve, which, as I said, is very involved in those parasympathetic nervous system responses. So we're getting to the end of the course here. We'll briefly touch on documentation just a little bit. Documentation is a very big, important job in emergency medicine because we have to document all of our patient encounters. There are a lot of people reading these charts, and we have to make sure we document things appropriately. First thing to always get when it comes to neuro patients, in addition to all of your normal stuff, is to really focus in on a complete patient history and all of their presenting complaints. We want to be as specific as we can about explaining why this patient is altered, what is different from their kind of baseline mental status, and what medical history that they might have. Want to document all vital signs that we get. We should always be getting a blood sugar and a temperature anytime altered mental status is present. Document a full mental status exam. Document any and all other vital signs that you get. Obviously, your blood pressure, heart rate, respiratory rate, oxygen saturation are kind of standard vital signs that we get on all patients, but make sure you are documenting that blood sugar and a temperature at a minimum in addition to your normal baseline vital signs. Make sure we document all assessments and exams. So if we do a thorough head-to-toe neuro exam, a stroke exam, we want to document that, and we want to avoid saying things like no deficits noted on a full neurological exam, right? We want to be very specific. We want to show that there was facial symmetry, that when they smile, their face elevated evenly. We want to be specific about the specific tests we are doing, rather than just saying we didn't see deficits, because that doesn't really show in the chart what examination we did. And 3 years down the road, if you have to answer questions about that chart, you're not necessarily going to remember what you did on that specific patient. So it's really important to document the specific neurological examinations that you do and the specific responses to them. It can take a little bit of time, but it's absolutely worth it. It's really important to document that information accurately. You then want to make sure you throw in a differential diagnosis. We're not expected to give one definitive diagnosis. We can't diagnose meningitis, but we can document that we had a suspicion of meningitis or a suspicion of stroke or a suspicion of seizures or any other neurological disorder that is out there. So whatever we think might be causing this problem, based on what we're seeing in our patient, we document a few things that we think might be wrong with them, right? A good differential diagnosis, but not a definitive diagnosis by any means, because that always has to come from a physician. And then, of course, document all treatments rendered. Document easy things like the position the patient is in. Document that you properly secured the patient. That's big on a lot of EMS systems, but anything that's going to support their airway, like elevating the head maybe in a stroke patient, document simple things like that. If you might consider it a treatment, if it helps the patient, make sure it's documented in the chart so it's very clear, it's documented, it is proven that that was done. Even if someone has to ask you a question about that chart 3 years later, you can look at that chart and see exactly what you did. That's kind of the goal there. So now let's touch on transportation. Transportation is always going to be kind of heavily dependent on local protocols and local guidelines because every EMS system is a little bit different. Some of you are going to work in areas where there are 10 different hospitals within 10 minutes of the scene you're on. Some of you are going to be in more rural areas where there's maybe one community hospital or potentially a bigger hospital a much longer distance away, and then you might have considerations to call air ambulance resources. So there's a lot of different decisions that might have to be made in a given EMS system. A good rule of thumb is that any unstable patient should always go to the closest emergency room. If they are hemodynamically unstable or if they have an unstable airway, if there's a life-threatening problem that can get fixed in the closest emergency room that you can't fix in the field, you always take them to that closest emergency room because we have to get that airway under control. We have to get them stable before we spend too much time transporting them. That's a general rule of thumb, but it's an important one to understand. If there's any reason to take a patient to the closest ER, you always should, right? If they need to get intubated or something like that at the closest ER, go ahead and take them there. But for other patients, right, we might consider for things like strokes, for pre-hospital alerts, we might consider bypassing the closest ER as well for patients who are stable. So that's always a decision that has to be made. When it comes to these patients, anyone who is critical, we always want to minimize scene time, right? We never want to be on scene for more than about 10 minutes of any patient who's going code 3 to the hospital. And we don't necessarily want to keep to a strict time either. We really just want to minimize it. We do not want to play around too much on scene. We fix airway, breathing, circulation problems. We get a complete history, so we aren't bringing a mystery case into the emergency room, and we get them moving when it comes to critical patients because we do not want to mess around on scene trying to fix things that we can't fix. Remember, there's nothing we do in the field that actually fixes a stroke or fixes a lot of these neurological problems. We're there to assess for it and get them to an emergency room that can manage their care. Always consider advanced life support and air transport resources depending on your EMS system. Those are just big things to always consider when you're thinking about additional resources. Always think about advanced life support, higher level of care, and air resources if those are necessary if you're far away from a big facility. Stable stroke patients should typically go direct to a capable facility. I kind of said that a minimum for stroke care is a facility that has a CT scan so they can determine if it is an occlusive or a hemorrhagic stroke. That's a good kind of rule of thumb, and it really just depends on your EMS system where you are supposed to take stroke patients. But stroke patients don't typically benefit from going to a community hospital that can't determine what type of stroke they're having because they can't get any definitive care, right? So they can't get clot-busting drugs, they can't get neurosurgery until they find out what type of stroke they're having. So we have to take those patients direct to a capable facility as long as they are stable, as long as their airway is under control, as long as there isn't a life-threatening problem that needs to get fixed in the closest emergency room. But again, it is very heavily dependent on local protocols there. Always refer to those local protocols, refer to local guidance, refer to the guidance from your own medical director and the folks who work in your area for transport priorities and the level of care that you are expected to deliver to a patient. So a quick review of what we've gone over in this course. It's been a pretty long course, but there's been a lot to cover when it comes to neurological emergencies. These are a very broad category of emergency medicine. It would be impossible to cover everything that might be considered a neurological emergency, but this is a great introduction to some of the more common ones that we run on in EMS. Remember, acutely altered mental status is a very common complaint, whether that is a chief complaint or an accessory complaint along with a different chief complaint, and it has a very long differential diagnosis. There are a lot of things that can impair mental status that we talked about. We went over that AEIOU TIPS mnemonic. We went over a lot of the potential causes in different age groups, and it just takes a lot of detective work sometimes when it comes to altered patients to figure out what's going wrong. And at the end of the day, if we can't figure out what's going wrong, our job is to get them to the emergency room, to treat them for what we can, and get them to a level of care that can take care of them. Thorough assessment should typically lead you in the right direction. That comes with a complete medical history, right? If are there clues in the patient's background that point you towards what's going on, do a really thorough mental status and stroke examination. That's easy in conscious patients who answer our AO questions. That's a little bit more difficult in someone with maybe a history of dementia, where their baseline mental status is a mystery to us, and we have to figure out exactly how they're presenting now and how that's different from normal. And then I always try to push a stroke exam for anyone with a neuro complaint of any kind, whether that is a mild headache, whether that's dizziness, confusion, or more obvious symptoms like one-sided weakness. Any altered patient, anyone with a neuro presentation whatsoever, should always get the most thorough stroke examination that we know how to do. And stroke exams are something you can kind of build over your career. You can add a few fun tests that you learn along the way. Good Cincinnati Stroke Scale, LA Prehospital Stroke Screen, MEND exam, throw in a good thorough cranial nerve and cerebellar exam on top of that. But the more stroke examination you can do, the more likely you're going to find strokes in the field that have more fine presentations than your big, massive strokes that we called large vessel occlusion strokes that we talked about. Vital signs, including a blood sugar and a temperature, and ideally a 12-lead EKG. As an EMT, you can't always interpret 12-lead EKGs, but you can obtain them, and if it says acute MI, it says STEMI on it, so you might take that into account depending on the protocols within your area. But a blood sugar and a temperature are really important vital signs to throw in on top of your other normal baseline vital signs. We've got to rule out blood sugar problems. We've got to screen for any signs of infection. When in doubt, always, always, always focus on those ABC problems, focus on immediate life threats, and transport the patient. You're not always going to be able to fix a neuro patient. There's really nothing we can do to actually fix them, and you're not always going to know what caused it. There will be patients who are a mystery to you, where they are acting funny and you can't figure out why. That is okay. Focus on the ABCs and get those patients into an emergency room. Get them to a higher level of care that can do a little bit more screening, a little bit more evaluation, and get to the bottom of what's going on with these patients. So always focus on those ABCs when it comes to emergency medicine. Treat what you can and get them to an emergency room. So that is the end of the course today. I hope this offered a good introduction into some of those neurological emergencies that we might run on in the field, and some of the treatments that we're going to render, or at least the assessment strategies we're going to employ to gain a good opinion about what's going on with those patients. So I hope you got to learn a little bit. Take a look at some of these references if you would like to. There are quite a few that'll offer a little bit more in-depth information about any topics you might have a question on. And have a great rest of your day. Thanks for coming in.
Now let's transition into some multiple choice questions.
First question. You are dispatched to an assisted living facility where the adult son of an elderly man reported that while they were talking, his father suddenly started acting strange about a half hour ago. He is showing symptoms of facial droop and a decreased level of responsiveness. You suspect an ischemic stroke. What is the window of time you have to get this patient to a treatment facility to assure the best possible outcome? Options include within 4.5 hours, within 15 minutes, within 6 hours, or within 12 hours. The correct answer is within 4.5 hours. Clot-busting therapy, known as thrombolysis, has to be given within the first 4.5 hours from the onset of symptoms to assure the best possible outcome. Next question. A stroke is caused by decreased blood flow to part of the brain. A stroke that results from a ruptured blood vessel in the brain is called Options include an ischemic stroke, a transient ischemic attack, atherosclerosis, or a hemorrhagic stroke. The correct answer is a hemorrhagic stroke. A hemorrhagic stroke is the result of ruptured blood vessels in the brain. This reduces blood flow to the part of the brain supplied by those blood vessels. An ischemic stroke is caused by a blood vessel blockage, usually due to a blood clot. A temporary blockage removed by the body's natural processes is called a transient ischemic attack, or TIA. Atherosclerosis is a disease in which calcium and cholesterol build up on the inside of blood vessels, which can eventually lead to a complete blockage. Next question. Your patient tells you she has Bell's palsy. Which cranial nerve is affected with this condition, leading to a presentation of one-sided facial paralysis? Options include cranial nerve 3, cranial nerve 5, cranial nerve 7, or cranial nerve 9. The correct answer is cranial nerve 7. Cranial nerve 7 is the facial nerve. Bell's palsy leads to a temporary paralysis of the facial nerves. Next question. Finding neurological deficits in a patient can be an ominous sign. Of the findings below, what is associated with the worst injury and decreased survival? Options include loss of sensation to legs, GCS less than 13, decorticate posturing, or decerebrate posturing. The correct answer is decerebrate posturing. Of these options, decerebrate posturing is the worst finding. Decorticate posturing also suggests significant injury, but generally not as severe as decerebrate posturing. Next question. Status epilepticus occurs when which of the following is present? Options include the patient experiences 2 or more seizures in a row without regaining consciousness in between seizures. The patient remains in seizure despite administration of midazolam. The patient screams while in seizure due to pain. Or the patient experiences seizure activity that lasts longer than 2 minutes. The correct answer is the patient experiences 2 or more seizures in a row without regaining consciousness in between seizures. Status epilepticus is a life-threatening emergency since a seizing patient has impairment of the ability to control their airway. Next question. You are dispatched to a private residence for an unconscious 55-year-old male. On arrival, his wife tells you that her husband was complaining of having the worst headache of his life when he woke up from a nap. Within about an hour, he had passed out while sitting at the dining room table. Your patient is currently unconscious and unresponsive with irregular, snoring respirations and periods of apnea. The patient has a history of hypertension and atrial fibrillation. Vitals include blood pressure 170/108, a heart rate of 66, and an SpO2 of 91%. What do you think your patient is experiencing? Options include ischemic stroke, hemorrhagic stroke, migraine, or transient ischemic attack. The correct answer is hemorrhagic stroke. Hemorrhagic stroke is characterized by sudden onset of symptoms, including coma. These patients may complain of experiencing the worst headache of their life prior to the onset of symptoms. History of hypertension is common in patients who experience hemorrhagic stroke. Next question. Your patient is a 71-year-old female sitting in a restaurant booth and appears lucid. She experienced weakness on the right side of her body and was unable to move her right arm or leg for several minutes. She also had a severe headache and felt nauseated, but states that all her symptoms have improved. Your patient most likely experienced which of the following? Options include transient ischemic attack, ischemic stroke, hemorrhagic stroke, or thrombotic internal stroke? The correct answer is transient ischemic attack. The classic signs of a stroke include paralysis and weakness to one side of the body, trouble with speaking, understanding, and a headache. In cases of transient ischemic attack, or TIA, these symptoms usually only exist for 5 minutes, after which the patient seems normal. Because a TIA is caused by debris or a clot that temporarily decreases blood flow to the brain, there are still risks that the patient may experience another TIA or stroke. This patient needs to be transported immediately for further evaluation. Next question. Which of the following is a potential complication of a stroke, spinal cord injury, or brain/brainstem injury? Options include Parkinson's disease, Alzheimer's disease, central pain syndrome, or Guillain-Barré syndrome. The correct answer is central pain syndrome. Central pain syndrome is the correct answer. Parkinson's and Alzheimer's disease's exact causes is unknown and not associated with trauma/injury. Guillain-Barré syndrome origin is an autoimmune attack of the peripheral nerves. The correct answer is central pain syndrome. Central pain syndrome is the correct answer. Parkinson's and Alzheimer's disease's exact causes are unknown and not associated with trauma/injury. Guillain-Barré syndrome origin is an autoimmune attack of the peripheral nerves. Next question. Which of the following branches of the nervous system is responsible for the fight or flight response? Options include sympathetic, parasympathetic, peripheral, or central. The correct answer is sympathetic. The fight or flight response is from the sympathetic nervous system. Last question. Which of the following is not a symptom associated with decorticate posturing? Options include flexed fingers, extended arms, inwardly rotated feet, or flexed wrists. The correct answer is extended arms. Decorticate posturing involves flexed arms into the core.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to emtprep.com. Until next time, stay sharp, stay safe, and stay on pulse.